All right, so cardiology, fortunately, unfortunately, is a large part of this business, as you well know. Some 50 to 55 questions on the board. So we're going to divide this up in this fashion. We're going to talk about diagnostic studies first, and then the physical exam, which for bizarre reasons they still think is important. And then we're going to talk about coronary disease, since we can't get away from that. Peripheral arterial disease, not my favorite subject, but it's on there too. Valvular heart disease, which is my favorite subject, and it's on there, thank goodness. Heart failure is always on there, and then we're going to talk tomorrow to close things out about ECGs, since they have some bare ECGs with nothing but "what is this" on the boards. Now, the references that I would use, other than the usual ones that you refer to, are go to the American College of Cardiology website, and you'll be redirected to cardiosource.org, so acc.org. If you choose the guidelines and quality standards under their science and quality menu, here is the Cardiosource website. You see there's guidelines and quality standards under the science and quality menu. If you choose that, you'll be directed to a list of guidelines. And the nice thing about the guidelines is that there are short forms of these guidelines available, so that you don't have to read the long version, which could be 150 pages long, and who wants to do that? But there's frequently a pocket guideline, which is a digital version, which is downloadable, and not only is convenient for you to carry around anyway. Well, how would you carry around a digital version? But you can download and print the downloadable version if you want to, or just refer to this and look at it to study from. But there are short pocket guidelines to refer to these things without having to waste time going into a long version. And these are the ones I suggest that you look at. And I would imagine that every single question that comes on the board would be on these guidelines. You know, I'm certainly going to refer to them as I talk to you. So let's talk about diagnostic studies and the chest x-ray. They still do have chest x-ray findings on the board, and for whatever worth it is, remember that severe heart failure has pulmonary vascular redistribution with, here are the plump pulmonary arteries up in the top part of the lung field. There also, this person has bilateral pleural effusions. And remember, curly B lines are engorged pulmonary lymphatics that are usually in the lower third or possibly in the middle third of the lung fields that attach to the outer borders of the lungs. And of course, there's cardiomegaly in this person and large pulmonary arteries proximally. This is the water bottle heart of a pericardial effusion, but of course it's not the diagnostic thing of choice for a pericardial effusion. That's echo. Here is pericardial calcification on a chest x-ray. One can see it here and laterally here, and diagnostically on a chest CT. And this is associated with tuberculous pericarditis and a few other causes of pericarditis, chronic pericarditis, but classically with tuberculous pericarditis, one must think, of course, of constrictive pericarditis when you see this. And then this is coarctation of the aorta, where you have loss of the aortic knob. So instead of the aortic knob being over here in the left side of the upper chest, there isn't an aortic knob here. And if you look carefully, there's rib notching, where the engorged arteries, intercostal arteries, have worn these notches on the underside of the ribs. Now, you should know the locations of pacemakers in the chest. This is a dual chamber pacemaker, such that one lead is curled up in the right atrial appendage. The other lead is in the right ventricle. And sometime they may, here's a single lead pacemaker with a lead in the right ventricle. And what they may want you to be able to recognize is that there is the lead in the right ventricle should go anteriorly towards the sternum and not posteriorly back here, which is a bad sign. I've had one, well, my colleagues have, I don't put them in. My colleagues have had them that have gone posteriorly through a patent foraminal valley into the LV, which is not a good place to have one sit permanently. So here's our first audience response question. We have lots of these in here, and I have to tell you that these things have been derived from questions that I have heard just through the grapevine, have been similar to those that might, is that enough qualifiers? That might have appeared sometime in the past on boards. So a 32-year-old non-smoking woman complains of increasing dyspnea, has elevated neck veins on examination. What study should you order? A ventilation perfusion lung scan, a CT scan of the chest, impedance plethysmography of the legs, an echo, or an ANA titer. Now this is a cardiology lecture, so I doubt if the VQ scan would be something I would talk much about. That's probably right. So an echo would give you more information than any of these other things about someone who had increasing shortness of breath at age 32. What would be the diagnosis that would come to your mind that the board would want on a question like that? Mitral stenosis would come to mind with a 32-year-old female. So let's talk about echo. Echo is good, is what this slide says, and it's good for practically everything that can affect the heart with structural heart disease and function. Remember, in particular, when we talk about dissection and peripheral vascular disease, that transesophageal echo is the diagnostic modality of choice for dissection of the thoracic aorta. So a temporary transvenous pacemaker was placed in the CCU. Minutes later, this patient developed hypotension and elevated neck veins, but lung fields remained clear. What would an echo show? LV dysfunction, acute AR, acute MR, hypertrophic cardiomyopathy, or a pericardial effusion. That's good, good. Now realize, of course, that the pacemaker's been placed on the right side of the heart, so it's pretty difficult to damage, at least intentionally, that'd be grim, a left heart structure, all right? So I hope we haven't done anything with a coronary artery. It's possible, but then the patient would have flash pulmonary edema, wouldn't they? If they had left ventricular dysfunction, they'd have flash pulmonary edema. They wouldn't have normal lung fields. It'd be pretty hard to damage a valve from a pacemaker insertion. That would be a heroic fail. I don't think somebody's going to develop a new pathology of hypertrophic cardiomyopathy by inserting a pacemaker, but I suppose anything's possible. And a pericardial effusion, of course, the pacemaker could protrude out through the not that thick right ventricle and cause an acute pericardial effusion. A 65-year-old woman with diabetes and poorly controlled hypertension presents with severe central chest pain. Chest x-ray shows widening of the mediastinum. Aren't there just buzzwords for certain conditions, right? This equals that. Widening of the mediastinum. ECG follows. What would you order next? That's an ugly electrocardiogram, isn't it? So would you anticoagulate with heparin? Emergency coronary angiography, transesophageal echo, a barium swallow, fibrinolytic therapy. Boy, there's ways to really really do some harm here, aren't there? This one's not as straightforward as the other ones are. See, it's not quite a bell-shaped curve, but it's getting closer to it. So what's wrong with this person? So clearly the mediastinal widening and the central pressure pain suggests a dissection of the aorta, correct? So then I throw at you this acute inferior MI, ST segment elevation event. Well, how does that go together with the history? Well, there's an ascending aortic dissection that has dissected the origin of the right coronary artery, causing an acute inferior MI. But the origin of this problem is the ascending dissection, which has dissected the origin of the right coronary. So a bad thing to do would be to anticoagulate this person, okay, or give fibrinolytic therapy, which would be a lethal thing to do. So I don't know what barium swallow would help you. Coronary angiography needs to be done, but you first need to make a diagnosis. And the diagnosis would be made by transesophageal echo, which we'll cover more of in peripheral vascular disease. So echo images on the board. This was 2011. I didn't update this yet. There are echo images on the board apparently. And I think the echo image was pericardial effusion, if I remember correctly. So there are some now. And I hope I did guess. These were my guesses of what might be on the board, and it was one of these. And so I think they're all fair game. Now, since the boards, of course, are on a computer, you can do anything once if they're on a paper, you're limited with 2D echoes. If they're on a computer, anything's fair, right? So I have those here for you. So here is a really, really large pericardial effusion with the heart here and the poor heart in the middle with this gigantic sea of water around it. And that's not subtle. I got this off YouTube. that repository of medical information. Actually, it's pretty good. I emailed a guy and he sent me the video. So that's a fairly large and not subtle pericardial effusion. It also has collapse of the RV here. See it being squished. Where's the right atrium? Well, the right atrium is right there and it is completely squished. So the person's actually in tamponade. Now, hypertrophic cardiomyopathy, in this case, you can see here's the LV cavity. This is the right ventricle here. This is the right atrium, left atrium. Here's the mitral valve leaflets. This is the posterior wall or the lateral wall right here. And this is the septum. And you can see that the septum extends from here clear over to here. And since the lateral wall is maybe a little bit thickened, but not much, but the septum is many times thicker than the thickness of the lateral wall. And this is the hypertrophic cardiomyopathy. You can also imagine that this is quite bright and whatnot, as has been reported with patients with hypertrophic cardiomyopathy. And the obstruction, if you're really a careful observer, you can even see that during systole, which is when the thing squeezes, of course, you can see that the anterior mitral valve leaflet gets pulled into the septum here. So this would be the obstructive version of hypertrophic obstructive cardiomyopathy, but nobody expects you to see that. They just expect you to be able to tell that the septum was miles thick here. They'd probably have an even better picture than I have here. Now, AS, this is the abnormal looking aortic valve on a transesophageal echo. Here's the three leaflets. Normally they should look like an upside down Mercedes-Benz hood ornament, and all the leaflets should open promptly instead of this calcified mess where you can see some little bit of motion here but not much. So this is a critical aortic stenosis. And the other one is just as obvious. This is another transesophageal echo. This monstrous chamber up here, which is about 5 times the volume of normal, is the left atrium. And this is the poor left ventricle down here, which is smaller than the left atrium. And that's because the mitral valve leaflets, instead of opening up down here like they should, all the blood is having to go through that little dinky hole, which is all that's being allowed in critical mitral stenosis, you see. So this is mitral stenosis. So that's what I would think they would stick on there, none of which are terribly subtle. All right, a Doppler-derived velocity across a stenotic aortic valve is 4 meters per second. So the flow across the aortic valve is 4 meters per second. What is the peak instantaneous pressure gradient across the valve? There it is in millimeters of mercury. So what is it? Good. So some of you have recognized that this is a fair game now. They want you to know how to translate Doppler flow velocities into pressure differentials. And so do you know the Bernoulli equation? Bernoulli was a French mathematician who, and physicist who came up with this. He had no idea it was going to be applied to cardiology in the future, but pressure equals 4 times the peak velocity squared. And how is that derived? We put a Doppler probe through the heart. I had a medical student ask me when I showed him this slide, says, "Doesn't that hurt?" No, that's ultrasound. Oh. So I said, we put a Doppler probe through the heart, and then we measure the flow velocity. See, here it is, that this is the portrayal of the velocity down here, and this is the systolic flow right here, and it comes up to be 4 meters per second. So you plug that into the Bernoulli equation to get 64 millimeters of mercury, you see. That's the flow from the LV to the ascending aorta is 4 meters per second, so the flow differential, the pressure differential is 64 millimeters of mercury. Normally in us, you see, it's like 1.2, 1.5 meters per second, so the pressure drop across the valve isn't very much. All right, what about stress testing? Here are the indications for stress testing. Suspected ischemic heart disease, risk stratification, particularly post-MI, assessment of the effectiveness of therapy, and establishment of an exercise regimen. Now, when you're faced with a question about whether it's reasonable to apply a stress test to somebody or not, you have to think about the history. And of course, the history has, the description of angina has 2 parts. It has whether the description is appropriate and whether the precipitating and relieving factors are appropriate. And if they're both present, that's typical angina. If one of the 2 of those is appropriate, then it's called atypical chest pain. And if neither are appropriate, it's called non-cardiac pain. Now, so what? Well, these are my own questions I ask someone when I'm taking a history of chest pain. And the 4 and 5 are the really great questions. What's the most active thing you do? Does that cause this discomfort to occur? So if they can do something that's whatever is their most physical activity they can do, and it does not cause their symptoms to occur, it's unlikely that their symptoms represent angina. And the other question is, what limits your activity? And I ask that by saying, if we were to go outside and walk around the block until you had to stop, what would make you stop? Now, if they say, well, my knee would give out, or I'd get short of breath, or I'd get tired, if they say those things before they would say I would get that chest discomfort, then their symptoms are unlikely to represent angina. Because angina is fairly predictable and reproducible, classical angina is. So I really beat this history to death, and you should on the board, you should be tuned into this. Well, again, what difference does it make? It makes a lot of difference for this reason here. What's the pretest probability of having coronary disease? If you're a young man or a young woman and you have non-cardiac chest pain, the pretest probability of having coronary disease is vanishingly low. So contrary-wise, if you're an older man particularly, and you have classical angina, you've got coronary disease. So then the utility of the stress test is a different thing. It's for a different purpose than for making a diagnosis. Do y'all understand this? Now, it just so happens that by Bayes' theorem, the probability that the accuracy of a test is greatest when the pretest probability is at 50%. So it is a pure coincidence, a useful coincidence, when that patients with atypical chest pain, middle-aged patients with atypical chest pain, have a pretest probability of about 50%. Those are the perfect candidates to use exercise stress testing for. That's the take-home message here. So if you're presented with a patient who has appropriate description, but the precipitating and relieving factors in the history on the boards are a little strange, that is the perfect person to use stress testing to sort out their chances of having coronary disease. It's not a great test for a 25-year-old female with non-cardiac pain. Do you follow me here? It's not a good test for the 70-year-old man with classical angina because he has coronary disease. So there's Bayes' theorem, I just said. So our false positive rate is quite high in patients who are unlikely to have coronary disease, and the false negative rate is high in patients who are very likely to have coronary disease. So why use exercise to begin with? Well, it mimics patients' normal activity, it's inexpensive, and it gives additional important prognostic information. How far you go on a stress test is extremely useful as far as prognostication. Patients who can go over 10 METs of activity have a 1% one-year cardiac mortality, right? If you can't go 4 METs on a treadmill, you're in a heap of trouble, regardless of whether you have ST segment depression or not. So here's the positivity on a stress test is related to ST segment depression. So here, why am I bothering you with this? Because they put on the board what kind of stress test you ought to give somebody. They expect a general internist to know this. So here's a basic ECG without any ST segment depression, a normal baseline ECG. And here's somebody with a positive stress test who has multiple leads with horizontal ST segment depression. So it is 1 millimeter or more of horizontal or downsloping ST segment depression that constitutes a positive test. Now, the limitations of exercise stress testing, a lot of patients obviously can't exercise, and the specificity of changes in the exercise ECG declines if the resting ECG isn't normal. So as the resting ECG gets uglier, for lack of a better term, roughly in this order, the specificity of any changes deteriorates. So that if you have Wolff-Parkinson-White left bundle or paced rhythm, there's no specificity in the ECG changes, and you have to add some other kind of imaging modality to improve the specificity of the test. Is that clear? Now, that doesn't mean there's no utility in exercising the patients, because if the patient can exercise to 10 METs and has no symptoms, what are the chances that they have severe three-vessel coronary disease? Or that their chest pain they're complaining about is angina? You see? Those things are still operative, even if you can't trust the ECG changes. So that doesn't mean I don't exercise patients. I may have to add nuclear imaging to that. All right, a patient with risk factors for coronary disease presents with chest pain and an MI has been ruled out. The baseline ECG shows LVH. What stress test should be ordered? So a regular exercise stress test, one with nuclear perfusion imaging, a chemical stress test with nuclear imaging, an ST segment sensitive Holter monitor, or cardiac catheterization. Good, good. That's very good. All right, you see that using exercise in a patient that can exercise is a good thing. So start with that. However, their resting ECG has LVH, and patients with LVH during exercise are more likely to get nonspecific ST segment changes, which may or may not indicate ischemia. Therefore, you can improve specificity by adding a nuclear component to the stress test, okay? Now, here's the flow chart. I got this from the chronic stable angina guidelines. This is the simplified version. So, is the patient able to exercise? And if the answer to that is yes, they ought to exercise. And then you ask yourself, is the resting ECG normal? And if it is, well, do a regular stress test. If it's not, then you ought to add perfusion imaging to that. The next one is, are there any contraindications to a vasodilator or dobutamine? So, do they have bronchospasm? Is there high-grade AV block? Is there valvular dysfunction? And if the answer to that is no, then is there a contraindication to dobutamine itself, which remember is a positive inotrope? So, do they have a prior arrhythmia, particularly VT, in which case you wouldn't want to use a positive inotrope, or are they markedly hypertensive? The answer to that is yes, we'll then use a vasodilator nuclear imaging. If the answer to that is no, we'll then use either one. Now, do they have a contraindication of dobutamine, which is all that stuff there? Then no, then use dobutamine nuclear imaging or dobutamine echo. Now, if they have a contraindication to both vasodilators and dobutamine, then you got to do something else. CT angio is a reasonable alternative, or coronary angiography, all right? A patient has severe claudication and asthma. Baseline ECG shows LVH. What stress test should you order? The same list here. Okay, good. So a regular exercise stress test would be out because the patient can't exercise well, and so therefore would also be out. An adenosine stress test is relatively contraindicated because of their asthma. Now you could try it with a syringe full of aminophylline ready. You could try it. It wouldn't kill them. You could try it and see if you could get away with it. It's just as easy to do a dobutamine stress echo. All right. Now, chemical stress testing is necessary if the patient can't exercise. And you can accomplish this with vasodilators or dobutamine as a positive inotrope. So myocardial perfusion imaging is accomplished by, you produce stress by some means or another, either by adenosine or dipyridamole or by a positive inotrope like dobutamine. And then the two agents typically used are either thallium or technetium. And these things are distributed where blood flow goes, where normal blood flow goes. And if blood flow is, what happens is that ischemia renders the pumps of the myocardial cell walls inoperative. So they can't uptake these isotopes into the cell during ischemic conditions. So if they normally would uptake these isotopes at rest, and then when the cell wall is rendered ischemic during some kind of stress, then they can't uptake the isotopes. So you see a differential between rest and the ischemia-induced stress. Do you see? Stress-induced ischemia, excuse me. So you can also see LV systolic function differential and so forth. So here is an older nuclear stress test, and all you really need to do is to look at this top panel here. These are tomographic cuts starting at the apex and going a centimeter apart until you get down to the base of the heart. So the apex of the LV is sticking out of the picture at you here. And you can see at the stress portion, let's start with the rest portion. The rest portion here looks like a donut because you're cutting the LV straight across. And if you look at the stress image immediately above it, you can see it looks as if somebody took a bite out of the donut. And this is a stress-induced area of ischemia on the nuclear scan. Now, stress echo is less expensive than doing it by nuclear technology. It just takes it takes three things. It takes a really good technician, sonographer, to be able to capture these images properly. It takes the proper equipment to be able to display the stress and rest images properly, because they have to be gated and they have to be timed so that they look like they're going at the same heart rate, because your head will take the faster beating segments and say those are contracting better. It's something your head does. It's very hard to get over. So they have to adjust the heart rates to look like they're the same, all right? And then it takes somebody who's really good at reading these and is used to reading them. And I guess the fourth component, you have to have really good images. So if somebody doesn't have good images, it's difficult to do this. All right, a patient with classical angina presents with classical angina. An exercise stress test shows ST segment depression in 1, AVL, V5, and V6. What coronary lesion would explain this? Good. That's a lateral defect. That's usually the circumflex, although it would depend on the coronary anatomy. A left main lesion would probably cause widespread ST segment depression everywhere but the inferior leads. Left anterior descending would classically cause V1 through, say, V4, V5. Right coronary would cause ST depression in 2, 3, and AVF. All right, what about cardiac CT? Well, there's two forms of cardiac CT. There's sort of a low radiation dose form that does not use contrast, and there's a higher radiation dose form that uses contrast. So in the non-contrast form, what used to be sort of called EBCT, or electron beam CT, this thing, the purpose of this is to detect coronary calcification. That's all it's for. So this does not use contrast and does not have a particularly high dose of radiation. So its sole purpose is to detect coronary calcification. This is not a CT angio, just a test to detect coronary calcification. And then the higher dose of radiation goes along with using contrast, and its purpose is to detect anatomy. Anatomy really is a CT angio. So the drawbacks of CT angio, of course, is that it does use a higher dose radiation. Whatever that means, it's the same dose as a nuclear scan, all right? It's the same dose as cardiac cath. Is that bad for somebody? Well, no one's ever shown it's bad for somebody, but it's 1,000 times the dose of a chest x-ray. So is that bad? Well, nobody knows. Now, non-contrast CT is mainly for the detection of coronary calcification, and a higher score, the score is correlated fairly accurately with the presence of coronary disease, but more accurately with the likelihood of having a cardiac event. This is the Agatston score, and the likelihood of having a coronary event is fairly well worked out. And we'll talk more about that when we get, well, we'll talk about it in a minute here. This, however, is a CT angio. This is one of our patients we had at the VA, a patient who had had angina, and at the time of coronary angiography, the right coronary couldn't be located. And this is the subsequent CT angio, which presents a very strange finding. This is the right coronary artery, and this is the aorta. This is the aorta, not this. This is the right ventricle, giving rise to the pulmonary artery. So this is the 88th case in the literature of the right coronary artery arising from the main pulmonary artery. This guy actually made it through the military, went to Vietnam, presented later on. This thing was functioning as a big vein, was backfilling into the pulmonary artery. And so we sent him to the surgeons. The surgeon has a really easy job here. He just detaches this from here and puts it over here. All right? But I can't imagine a diagnostic tool that would have been better for displaying this than the CT angio would have been, see? Now, this is what it looks like to do a CT angio of coronaries. This is the coronary tree. These are cross sections of the coronary arteries. These are the coronary arteries laid out. You can see that there is, do you see any calcium here? Which would be white, bright white flecks? No, I'm happy to say, these are mine. And this was one of my colleagues who was a health nut. We had to get our CT angios done when my cardiology colleague who does these got a new scanner and said, well, I'm calibrating the machine. So we all had to get ours done, and one of my colleagues who's the health nut had a calcified left anterior descending, and he said, oh, you've got to get yours done. You know, you're heavier than me, you don't exercise as much as me, so here are mine. Thank you very much. And he thought this was not fair. Well, so this is better than a stress test. So at any rate, here's what coronary calcification looks like on a plain CT scan of the chest. When it's this bad, things are grim. So you can see the calcified coronaries here. And this is you don't need to remember this chart. I just put it here for your interest. The higher the Agatston score, which is on the left here, the more likely it is that someone's going to have a coronary event. So why am I putting this in here? Because it is now indicated for certain groups of patients to have not a cardiac CT angio, but a calcium score is part of the guidelines now, which we'll get to when we talk about coronary artery disease. So what about cardiac MR? LV function, tissue characterization. There are certain things that look different under cardiac MR, particularly some of the cardiomyopathies. Amyloid, hemochromatosis, some of these things look different under cardiac MR. Myocardial masses, we have some amazing stuff we could show you if I was doing a show and tell, but I'm not. So myocardial viability is also a very big area for cardiac MR. This is one of those things. This area of myocardium down here, this area is scar. No amount of revascularization will ever make this into a moving area of myocardium. So it would be no sense in revascularizing the inferior wall of this myocardium. Now, what about PET? PET is also a good way to determine myocardial viability because viable myocardium utilizes glucose in its metabolism. SCAR does not. So in this scan, N13 ammonia is a positron emitter that goes where blood flow goes. So you see, here's the lateral wall of the LV, and the septum is right here. So there's no blood flow to this person's septum. Now, is the septum alive or dead? It's not going to move on echo, is it? Because if you don't perfuse it, it ain't going to move. It would have a big fixed nuclear defect there because it's not moving and it's not perfusing. So this would be the same as having this is a fancy way of doing a nuclear scan, a regular nuclear scan, and the septum wouldn't move. Is it dead? Would it help to revascularize this segment? A PET scan using fluorodeoxyglucose, in which the glucose molecule has a radioactive fluorine atom on one of the glucose ring as the positron emitter, shows that the septum is metabolizing glucose, meaning that it's not dead. It would respond to revascularization. You understand? So this is a viable segment. All right, what about cardiac catheterization? All contraindications are relative, except I guess the one where the patient won't sign a consent. A patient has coronary angiography from the femoral approach. Immediately after the procedure, she develops sinus tachycardia and severe hypotension. A 12-lead ECG is otherwise normal. What is the diagnosis? So immediately after the procedure, she gets sinus tachycardia and hypotension, but the ECG is normal. So does she have an acute MI, a retroperitoneal hemorrhage, tamponade, pulmonary embolism, tension pneumothorax? So say you're a hospitalist and the angiographer does this. It doesn't have to be a coronary angiogram, does it? It could be something else. Yeah, this is really common. If you saw the ugly peripheral vasculature that we have to go through to get to the heart, you'd think that this would happen more than it does. And the diagnostic procedure of choice would be a CT scan, of course, of the abdomen. A lot of blood can sit down in the pelvis. Be pretty grim to cause a tension pneumothorax doing a coronary angiogram. Okay. A 75-year-old woman had a coronary angiogram 3 weeks ago. Over the past week, she noted discoloration and pain in the right foot. Her lab data shows a creatinine of 4.5. What's responsible for her renal failure? There's the ugly foot. All right, does she have underlying kidney disease? Contrast nephropathy, atherosclerosis of the renal arteries, an allergic reaction to contrast, atherosclerotic embolization to the kidneys at the time of the cath. Okay, good, excellent. So you don't have to have kidney disease to have this problem. Its presenting time is perfect for emboli to the kidneys at the time of the catheterization. Contrast nephropathy, that's not how it presents with this kind of discoloration to the foot. You don't need atherosclerosis of the renal arteries to get this. Contrast allergy, there really isn't an allergy to contrast. It's a histamine reaction. to contrast, and that's not really a true allergy, and it happens immediately anyway. But that's a classic atherosclerotic embolization of the kidneys. All right, right heart catheterization. So the pulmonary capillary wedge pressure is a dampened form of left atrial pressure, which represents left ventricular end diastolic pressure, which is what we really want. Whole careers have been developed at trying to find a non-invasive way of finding left ventricular end diastolic pressure by echo, and nobody's been able to do it. If there was a simple way to do that, nobody would do any right heart caths anymore. Well, almost nobody does anyway, for the sake of having echo, you know. So normal is less than 12 millimeters of mercury, and it goes up with anything that bothers filling pressures. And of course, the higher it is, the more symptomatic the patient is, and an acute increase produces much more symptoms, many more symptoms. The patient's much more symptomatic if it accumulates rapidly rather than slowly. All right, now what about right atrial pressure? Normal right atrial pressure is rather low, and jugular venous distension occurs at anything more than about 5 millimeters of mercury. Now, a 57-year-old man with lung cancer presents 24 hours of increasing dyspnea. Blood pressure is 85/40. Neck veins are elevated. The right heart pressure follows. What is the diagnosis? So there's a right atrial pressure, which is what? 4 times normal? Pulmonary artery pressure and wedge pressure. So is that pulmonary embolism, acute MI, constrictive pericarditis, tamponade, or pneumonia? Boy, do they love this stuff. Chances of having this kind of stuff on boards is just exceedingly high. Okay? What's the key feature of those pressures? Equalization of diastolic pressures. Exactly. And we'll talk about that again in just a second. So let me hold most of my stuff for just one more second. Why isn't it acute MI? Well, because acute MI is not usually going to produce equalization of diastolic pressures, and usually is not going to present with that constellation of symptoms in a patient with. The key to this is the understanding the etiology of this. This man has lung cancer. What else? Where would that work into this? He probably has a malignant pericardial effusion, which works into this thing. Why get constrictive pericarditis into this? There's no reason for him to have constriction on top of this, and it doesn't occur in 24 hours. The time course is wrong, but the time course is perfect for tamponade. Now, here is where we'll talk about this some more. Now, can you imagine that they will put something like this on the test? Or they could do it. So here are the examples, and they're the normals across the top. And of course, they're going to ask you the diagnoses for the rest of these things. Now, how would I approach something like this, other than going, oh my gosh, right? Here's how I would do this. First thing I looked at was every right atrial pressure is sky high, okay? So your mind may work in an entirely different way than mine. So if you don't like this way, think of your own way, that's okay. But this is how my mind would work through something like this. So every right atrial pressure is sky high. So that has to mean there's the common feature among all these things. Second, 3 of these things are hypotensive, severely hypotensive. So 3 of these diagnoses are an acute illness. They have to be something that's an acute illness. You don't walk around for a long time with a blood pressure 70/50, right? You're going to die. So 3 of these have to be acute, and probably the other 2 are chronic. So that's a pretty good way to differentiate them. Next thing, 2 of them have wedge pressures that are really high. That means they could be left heart problems. Okay? So 2 of them are really high wedge pressures, which could be left heart problems. Now, 2 of them have exceedingly high pulmonary pressures. That limits the playing field really severely. There's only a few things that have pulmonary pressures that are this high. And would you see, they're both chronic problems. And one of them has a high wedge pressure and one doesn't, which, by the way, gives you the diagnoses right off the bat. Okay, this one has equalization of diastolic pressures and is an acute problem. So guess what? There's a freebie right off the top. So what acute problem has equalization of diastolic pressures? Only one I can think of. Well, that's not true. Tension pneumothorax would do this, but they're not going to give you that in the differential, right? So let's talk about this first one. Very high right atrial pressure, equalization of diastolic pressures, and the person's acutely ill. That's got to be tamponade. Nothing else would play out that way. Okay, only a few things give equalization of diastolic pressures. Tamponade, constriction, tension pneumothorax, severe status asthmaticus, okay? That's about it. And this is an acute illness, so this has to be tamponade. They're not going to give you the other 2. This is a cardiology question. Okay? Constriction is not going to make you acutely ill, so it's not in there. Now the next one, here's somebody who has a high right atrial pressure, is acutely ill, so this is an acute process, and they have this ridiculous low wedge pressure. So this is a right heart problem, isn't it? This is a right heart problem. Now, there's only one acute illness that I know of that will give a right atrial pressure to wedge pressure ratio like that. That's an acute illness and cause hypotension like that, and that's an RV infarct, a right ventricular infarction. We'll talk about that when we come to ischemic heart disease. But that's the only one that's in play when you talk about the RA being elevated to the wedge pressure like that and associated with hypotension. We'll talk more about that one. This one. This is the one with the big wedge pressure. Well, guess what? That's got to be a left heart problem. And here you have high pulmonary pressure, high right atrial pressure, and the person's in shock. Well, what do you call this? Cardiogenic shock, right? This is a person with a big MI. So that's plain old cardiogenic shock from a large myocardial infarction. The left heart problem. Now, let's talk about the 2 with severe pulmonary hypertension. Well, one of them has a very high wedge pressure. This is a left heart problem that has an exceedingly high pulmonary artery pressure. And I only know one thing on the left side of the heart that gives a pulmonary pressure like this. Only one thing. It's really not the left ventricle's fault. This is classic mitral stenosis. Only mitral stenosis gives right heart pressures like this. Other valvular heart diseases don't do this. And left heart failure doesn't do this. This is mitral stenosis. And what's that last one? Is this the left heart's fault? No. This is the lungs' fault, right? So this is some kind of severe lung disease. Primary pulmonary hypertension, multiple pulmonary emboli, something of that kind, right? All right? So it's not too bad, but you have to have some scheme or system to work through this. Endomyocardial biopsy, a word on that. It's useful in doxorubicin toxicity and transplant rejection. And certain things of that kind. It's useful in amyloid, but you can get that biopsy from other places. You don't need to biopsy the heart. Okay. 35-year-old woman presents with a history of substernal pressure sensation lasting from a few minutes to as long as 4 hours. Okay. Non-cardiac pain, atypical chest pain, or classical angina. She does not get the pain with activity, but occasionally has it when lying down. Non-cardiac pain, atypical chest pain, classical angina. Huh? Well, no insurance company is here. Nobody's going to sue you if you get this statement wrong. What pain is it for this purpose of the test? It's non-cardiac pain. There's nothing about this. Neither the description or the precipitating or relieving factors are appropriate for angina. Okay? All right. So what's her pretest probability of having coronary disease? 2%. She does not get the pain with activity, but occasionally has it when lying down. Risk factors include hypertension or obesity. Which of the following is true? Do you see why this is important to know when you answer a question like this? 2% pretest probability. She has a 50%, greater than 50% chance of having significant coronary disease. Heck no. Okay? An exercise stress test would have a high degree of accuracy in this patient. No. Exercise duration would not be useful in predicting prognosis. Ridiculous. Of course it would. Nuclear perfusion imaging would improve the accuracy of the exercise study. Yes, it would. You see? Something would have to. Do you understand? Really, does everybody understand that now? Okay? 2% pretest probability of coronary disease. All right. A 65-year-old man has been having chest pain during his 5-mile walk every day. Non-cardiac pain, atypical chest pain, classical angina. Classical angina. It's a real thing. Does he have coronary disease? Of course he has coronary disease. He exercises on a treadmill for 13.4 minutes. How many of you could do 13.4 minutes if we went out right now? Some of you probably surely could. We had one of these triathletes got on our treadmill, one of the residents. We had to make up a protocol because the Bruce and those things wouldn't work. So we just let the treadmill rip, and he went 20 minutes on the thing going as fast as it could. 20 minutes. We estimated the MET level was something like 26 or 27 METs. Finally tired him out. Okay. He exercises on a treadmill for 13.4 minutes, peak heart rate 155, and has 1 millimeter of horizontal ST segment depression that rapidly returns to normal in recovery. What would you recommend? Secondary prevention for coronary disease, urgent cardiac catheterization, diltiazem and aspirin. Repeat the exercise study with a nuclear perfusion imaging, aspirin and an ACE inhibitor. Everybody hates me when I do this question. I get so much guff from this question. See? That's exactly why. So he goes 13 minutes on a treadmill, and his 1-year prognosis is less than 1% 1-year cardiac mortality, and he needs urgent cardiac catheterization? The Duke diagnostic score would give him a 0.25% 1-year mortality, and he needs urgent cardiac catheterization? The right answer is secondary prevention. Okay. None of the rest of these, diltiazem and aspirin, aren't indicated for coronary disease. He certainly doesn't need another stress test. He has a positive stress test, doesn't he? He gets 1 millimeter of ST segment depression. You don't need to do it again. Aspirin and ACE inhibitor aren't indicated in this guy. He doesn't need an ACE inhibitor. Talk to me later. I don't know the answer to that. Everybody would cath him. I know that. What kind of invasive intervention would prolong his survival? When we come to the coronary artery business, you tell me what kind of invasive intervention would prolong his survival. None. If his symptoms could be controlled with beta blockers, all right, a 63-year-old woman, contrast that with this. A 63-year-old woman reports a history of effort-induced chest pain. What kind of history is that? Classical angina, right? On a treadmill, she exercises for 4 minutes. How much is that? Activities of daily living, right? Peak heart rate of 110, that ain't much, and has her typical chest pain. ECG at rest and at peak exertion follow. There's rest, there's peak exertion at a rate of 110. Well, this isn't even 110. So how many leads does she have ST segment depression in? Let's see, 1, because you got an AVR, she has elevation. 2, 3, 4, 5, 6, 7, 8. Okay? Reassure the patient as this is a low-risk treadmill. Repeat the test with nuclear perfusion imaging for greater accuracy. Institute secondary prevention alone. Urgent coronary angiography. Refer to a psychiatrist for treatment of an anxiety disorder. There's always some comedian in the audience who put you on, see. There's always somebody. Okay, so you see the difference between these patients? All right, so one is an extremely high-risk situation. The other, no. Are you likely to prolong this patient's survival with revascularization? Yes. You're likely to find anatomy that would result in prolongation of survival with revascularization. All right, so this is a sword-billed hummingbird male. The female has a longer bill. Guango Lodge, northeast slope of the Andes at 9,000 feet last fall. Okay, so let's see, what's next? And that really is that long. Can you imagine? When they sit, the bill is so heavy, they have to sit with the bill up in the air like this. They sit with the bill straight up in the air. It's too heavy to hold straight out. That's a tongue sticking out there. Okay, part 2, physical exam. That's my other life, photography. Okay, so pulsus paradoxus, there's no Latin on the board, so this is referred to as inspiratory fall in the systolic blood pressure. Pericardial tamponade causes this, asthma, and tension pneumothorax. For all practical purposes, this is tamponade. Okay. So if you have the person breathe in and their systolic blood pressure falls, this is an example of inspiratory fall in systolic blood pressure. It's easier to say pulsus paradoxus. A bifid arterial pulse occurs with aortic regurgitation and hypertrophic obstructive form of cardiomyopathy. Pulsus alternans, the old Latin form, or alternating arterial pulse, occurs in some patients with severe LV dysfunction. It also occurs with ventricular bigymony, with a PVC being every other pulse, or a PAC being every other beat. And severe aortic stenosis can do this too. That's rather a large gradient, isn't it? Decreased rise time and volume of the arterial pulse is classic for aortic stenosis. Aortic dissection produces asymmetrical pulses, and of course peripheral vascular disease can produce pulse deficits. A patient with known severe coronary artery disease and heart failure presents to your office with elevated neck veins. This is just plain old ordinary left heart failure. So what pattern of neck vein abnormalities are you likely to see in the neck vein in plain old ordinary left heart failure? So there they are. And if you're like most people, you just sort of push the button randomly. Man, it looks kind of like that. Yeah. So the answer is A, and I will try and be as brief as I can with the explanation with this, because it depends on, someday they have in the past, but they'll cycle around and hit this again, and then I'll be happy that I helped you with it. I don't want to waste your time with it either. This isn't supposed to be a teaching session about physiology. This is supposed to be a board review. So I have to be very careful not to waste too much time here. But in any case, large A waves and large A waves and V waves is the answer, okay, and B. Large A waves on a slow Y descent, A, that's tricuspid stenosis. Rapid X and Y descents is tamponade. Regular canon A waves are, well, that could be AVNRT, the arrhythmia would do that. And distended neck veins with no pulsatile activity, that's superior vena cava syndrome with cancer obstructing the venous drainage of the neck, or tension pneumothorax will do that too. So let's talk about this for a second. What's the A wave from? Think about this, that this is ventricular systole here, and this is ventricular diastole out here in these white areas. What's the A wave from? The A wave is easy. It's from atrial systole, right atrial systole. Then forget the C wave, who cares about that? Let's just talk about A, X, V, and Y here, that's all. Now what's the X descent caused by? Well, because when the right ventricle and the right and left ventricle contract, the whole heart falls down in the chest. This is the main thing. I don't think anybody talks about this enough. I finally had this epiphany when I was looking at an echo one day and happened to notice that the whole thing was, we look at it upside down when we're doing echoes. So I took the whole echo and I turned it upside down, which I've got here next slide or so. And you can see that the whole heart during systole falls down in the chest, and that pulls the floor of the right atrium down about 2 centimeters. That's the main impetus of the X descent. The whole right atrium falls down in the chest. And so this is the cause of the X descent. Now then, as the ventricles start to relax, the floor of the right atrium comes up again, and it's filling passively. So that's the V wave as it starts to occur, as the right atrium is filling passively, and the floor of the atrium starts to come back up again. Then, as diastole, ventricular diastole starts, the tricuspid valve opens, and all that blood cascades into the RV. That's the Y descent. Then it starts over again. So the main thing is this X descent is caused by this downgoing of the whole heart when systole, ventricular systole, pulls the whole thing down in the chest. And now here's the normal right atrial motion. Here's the right atrium over here, see? And you can't appreciate the fact that the whole right atrium is moving around from this 2-chamber view. By the way, what's wrong with this person? Do you see the septum here? And the fact that this whole portion right here does not contract. There's the thin myocardium. So this is a coronary artery disease, a big segmental wall motion abnormality. They've had an infarct related to the distribution of the left anterior descending coronary artery. But we're concentrated over here with the right atrium and the right ventricle. Here's the tricuspid valve. All right, well, let's turn this whole thing upside down. If this thing were playing, you could see that the right atrium is moving up and down with respect to this red line. And during the X descent, it falls way down here, and then at other times, it comes back up to this red line. All right, I can try it on my cardiac MR. I had our MR person, Tiffany Priester. She is our MR expert. Line all this up on a normal patient with the neck veins clear up here. Here's the superior vena cava. Here's the right atrium going clear down here to the right atrium and the RV down here. Watch the motion. Oh, it's not a video either. At any rate, if this were the video that I should have provided, then you could see also that the tricuspid valve is moving from here clear over to here, back and forth. So it's the motion of the right atrium up and down that's causing this X descent. And so with that in mind, you can appreciate that the X descent is quite dramatic. Now, how do I measure the neck veins in my practice? Okay, I had one that this woman said wanted us to see, as a primary care provider wanted us to see the patient, and she had wanted to know what was wrong with the patient, why he was short of breath. And the echo showed that he had a pulmonary artery pressure of 55 to 60. And I went back to her original evaluation of the patient. Lungs clear to auscultation and percussion, neck normal, heart normal. I looked at the echo, which was done 2 days before. Inferior vena cava is dilated and does not change with respiration. So I wrote her a personal email. I didn't put it in the chart, of course. I wrote her a personal email. I said, I'm not trying, please take this properly. There isn't a way in the world that that patient's physical exam was normal with that echo. And I wrote out a long thing about how to do a physical examination on somebody that was short of breath for the first time, hadn't seen a doctor in 10 years. And I said, you don't have to do very much, but there's no way that patient had normal neck veins. I said, what you get in trouble about is because you examine the patient almost recumbent. And the neck veins, I guarantee you, were above his ears, and you didn't see it for that reason. So what do? I set the patient up on the side of the bed to examine neck veins. If they're above the clavicle in the sitting position, they're up, okay? None of this 45 degree, I don't care about that. Are they above the clavicle in the sitting position? Then they're up, right? And I'll bet this guy's would have been to his ears in the sitting position, and she just didn't know they're that high. I said, do that, look for a left parasternal lift, listen over the right side here for a right-sided third heart sound, then roll the guy up on his left side, palpate the apical impulse, see how big it is. Is it more than 3 centimeters in diameter? And listen with the bell right there. Does he have an apical S3? That's it. That's all you got to do. Now, it takes time to do that right. I mean, it takes time to get used to trusting yourself to do that right, but that's it. That's where all the money is. I said, I'll bet you none of those things were normal. So, you know, I tried to be really kind to her. I wasn't trying to chew her out or anything, but it was clear that she had not recognized how bad this guy was. So, anyway, that's exactly what I do. You guys can do this as well as anybody else can. It's just a matter of pattern recognition. Okay, so large A wave, you can see this. You know, if the blood can't get through the stenotic valve, of course, when the atrium contracts, it's going to have a big A wave, right? So tricuspid stenosis will do that. Now, irregular canon A waves, they like to ask this one. And what would happen is, this is the sine qua non of AV dissociation. And what happens is that the right atrium is contracting against a closed tricuspid valve occasionally, okay? Now, what closes the tricuspid valve? Well, ventricular systole does, you see? And when would that happen? During ventricular tachycardia, if the patient's still in sinus rhythm. That'll occur in 70% of VT, so you have irregular canon A waves. And third degree block is the classic situation. See, here's VT, and here's the patient's P waves running along here, which you can sort of faintly see in the middle of this business. And at the time when there's a P wave associated with a ventricular beat, the atrium contracts, but where's the blood going to go? It can't go in the ventricle, so it goes boom up the neck. Irregular canon A waves, you see. This is the easy one to understand. Here's a patient in complete heart block. So at the time when there's a coincidental P wave, see the P waves along here? When there is a coincidental timing between the P waves and the QRS complex, you'll get a canon A wave. And it's irregular. That is the dead giveaway of AV dissociation and complete heart block in this case, you see? All right, now here's the big table. All of the different causes of changes in neck veins. How many of those will they ever ask? I'll go over some of these later when it comes to the specific diagnoses. I've already talked about a few of them. We'll go over some of them specifically. A young patient presents with a second heart sound, this is one of them, that does not vary with respiration. An ECG shows RVH and right atrial enlargement, although you don't need that. What is the diagnosis? Mitral stenosis, well, that stuff. Which one? Yeah, most of you got that. Good. That's a 1-for-1 answer. One disease, one physical finding. So a fixed split is the other way it's put, but they usually don't use that terminology. Does not vary with respiration. It's an ASD. All the rest of them do have second heart sounds that vary with respiration. Okay, now, why do I show you this? For a reason. There's the mitral valve apparatus, posterior mitral valve leaflet, anterior mitral valve leaflet. How many times, I got this really slow. So there's the start of diastole, and there's the start of systole. So that's diastole, and there's systole when the mitral valve leaflets are closed. How many times is that open in diastole? Huh? Now, this says normal up here, doesn't it? Okay. So does that mean that yours is like this? So yours opens twice. I had medical students who say, mine doesn't. Okay. So here we put the Doppler probe through the heart, and you have, here's a mitral valve leaflets, and we sample from right there, which is the LV side of the mitral valve. And by convention, all the flow that's towards the transducer, which is up here at the apex, is presented above this line, and everything away from the transducer is below this line. So here's the beginning of systole, which is the QRS complex of the ECG. So no flow here, and then the beginning of diastole occurs, and here's a flow towards the apex. So the mitral valve leaflets open up, and this flow occurs, and then that flow starts to peter out, okay? And the mitral valve leaflets start to shut, and would go shut, except for this, which follows this bump, which is the P wave. And left atrial systole occurs, and opens the mitral valve leaflets the second time, and has the second flow. You all see that? Now, if you were to auscult the patient and heard a low-pitched sound at the apex, this would be a third heart sound, coincident with this flow. All right? Now, a low-pitched sound at the apex coincident with this flow is an S4. You all get that? Okay. That's the best way I know of helping people understand when these things occur. Okay, so how do you change the intensity of S1? Well, think about this. Look up here for a second. Let's suppose you had a real long PR interval. Okay? Let's suppose this P wave occurred clear back here. And this flow then would occur immediately after that P wave, after atrial systole. So it would fling the mitral valve leaflets open, right? What would keep them open? Nothing. So they would start to drift shut. And eventually, left ventricular systole occurs, And how much noise would they make shutting from this position? Not much, right? But let's say you had a short PR interval. What position are they when ventricular systole occurs? Okay? So I try not to memorize junk, but to make sense of it, because then it sticks. All right, what about a physiologically split second heart sound? When you breathe in, you decrease intrathoracic pressure, and that increases venous return to the heart, and therefore the right heart, which is more sensitive to these changes, delays closing a little bit, delays P2 a little bit. And so P2 lags out behind A2, and that's physiological. I actually have one here, see that? So that's the top, is the physiological delay of P2. Now, let's say you have pulmonary hypertension for whatever reason. You got chronic lung disease or something, pulmonary pressure of 55 or 60 or something. P2 still moves, but it never gets back to A2. So this is a widely split second heart sound with pulmonary hypertension, or persistently split. It still moves. This is not a fixed split as you will find with ASD, all right? But this is persistently split, you see? Someday they'll not bother you with this anymore. Get the echo and see what the pulmonary pressure is, right? Okay. Now what about a paradoxical split? Think aortic stenosis when those words are used. And what happens? A2 moved in paradoxical splitting. See the bottom one? A2, why is A2 moved? Because it takes forever to empty the LV through the stenotic valve. So A2 has moved, and in this case, P2 still moves normally, but now it approaches A2 during inspiration instead of expiration. That's the paradoxical part. Understand? Okay. Think aortic stenosis. Fixed split or doesn't change with respiration, ASD. Now, why bother you with something as trivial as the pulmonic ejection sound? I've heard it never. Why have I heard it never? Because they don't get in the military. Because you have to have serious congenital heart disease to have this, and they would never get in the military. So they would never be a veteran, you see. Why bother you with it? Because it is the only right-sided sound that gets softer on inspiration. Every other right-sided sound gets louder. And the people who write the board are idiots. And they love stuff like this. And they're just as likely to stick it on there as anything else, just for that reason. Tricuspid regurg murmur gets louder, pulmonary insufficiency murmur gets louder, right-sided S3 gets louder, every other right-sided sound gets louder with inspiration, except this. If you want all the explanation, come ask me in the break. I'm not going to bother everybody with it now. All right, and S3. And S3 is bad. If you're an adult and not pregnant and you have an apical S3, that's a bad thing. It's a bad preoperative finding. It's a bad prognostic finding. If they give you this on a test question in the history or the physical exam part, the patient's sick and they're high risk. There's nothing more specific about bad heart failure than an apical third heart sound. And S4. All right. A 43-year-old woman presents with primary pulmonary hypertension. Okay? So you can see this person now, right? Big neck veins, left parasternal lift, right-sided third heart sound, pulsatile liver, all this kind of stuff. PA pressure is 95. What would you expect to hear on auscultation of her second heart sound? A soft P2, widely split second heart sound, single second heart sound, paradoxical splitting of the second heart sound, a fixed split of the second heart sound. Yeah, so it's widely split. Still moves. I showed you the graphic, showed you the motion picture, right? P2 always lags out past A2, but it still moves. Widely split. Not paradoxical, that's AS. Paradoxical splitting, AS. Paradoxical splitting, AS. Okay. Fixed split, ASD. ASD. Which of the following on a preoperative evaluation indicates the highest risk? Do you need to see the answers? I got a pre-op consult 2 days ago or something, 3 days ago, and it said, that we're going to take him to vascular surgery, peripheral vascular surgery. And it said, patient had shortness of breath, so we got this echo. We canceled surgery. We'd like you to have him review him before we clear him for surgery. And the echo showed a 15 to 20% ejection fraction. And I said, first of all, cardiology does not clear patients for surgery. We assess risk, but if I were to clear a patient for surgery, this would not be him. So, yeah, S3 is bad. Okay, so this is a Tyrian metal tail, also at Guango Lodge on the east slope of the Andes, Ecuador. Name for the pretty tail. Coronary artery disease and myocardial ischemia. So angina is caused by a mismatch of myocardial oxygen supply and demand. It can be either stable due to concentric plaques or unstable, usually due to a plaque rupture. Here's the first movie I ever made. So here is 20 years in the life of a plaque. So you see here's the plaque developing, and there's foam cells that move in here and fibroblasts over the plaque and so forth and so on. And everything's just slowly developing until you see this ominous bulge, kind of like, you know, Mount St. Helens over here. And this all takes 20 years, but this only takes a few seconds. See, boom, and then the plaque ruptures and there's clot formation. So here's a stable plaque. And you see that this is this. Look at the thickness of this intima here. See, this is supposed to be just a tiny little layer, and in this patient, it's like a millimeter thick, huge thick intima here. And below it is this big, ugly collection of fat and cholesterol and calcification and whatnot. This intima is not going to rupture. So this is not a dangerous plaque. If it's going to rupture anywhere, it's going to rupture at the edge where it's growing. However, this is the thing that this is the bad thing. You see, here's a thin place on the intima, and this has ruptured, and this has killed the patient. Otherwise, we wouldn't have a pathology slide here. And so it has dissected underneath the intima, and caused this stuff to be raised away from the media and dissected clear down in here. You can see the blood staining. And worst of all, if there's this big thrombus, you see. So this is how you take a stable plaque and go to an unstable plaque in the matter of a few minutes. So the prognosis in coronary disease is related to LV function, which is always the big prognosticator. So if you're confronted with a question that wants to know the prognosis of this patient, and they give you data on left ventricular function, it's always related most to the patient's LV function. They may give you that by an ejection fraction. They may give you that by a physical examination, which shows an S3, which is a bad thing. So they may give you that data in various ways, but the patient with the best LV function has the best prognosis. And it doesn't matter if they're talking about coronary disease or valvular disease or arrhythmias or congenital heart disease or pre-op evaluation or whatever they're talking about, this holds. If they're talking about adolescents with congenital heart disease, it doesn't matter. LV function is the great prognosticator. Is that clear? Another powerful prognostic thing is exercise capacity. If someone can do a lot of METs of activity, everything else kind of falls by the wayside except LV function. Now, let's talk about risk assessment in asymptomatic patients. Boy, is this a hot topic right now. So, of course, you should assess risk on all patients, all asymptomatic adults, without a history of coronary disease, using one of the scores. There's the new, this is where the controversy comes in, the new American Heart Association ACC calculator. You can download this thing. They have it as an app for smartphones. And it allows you to have a 10-year and lifetime risk assessment, and also gives you an idealized one over here in this column. I picked somebody who had every risk factor I could think of and came up with a 68% 10-year risk of having an atherosclerotic event. Mine was 7%. So I came in just under the nose, or right at the nose, of having to take statins, right? So I'm not taking them. Plus, I don't have any coronary calcification, so I cheated. So at any rate, so if the risk is high, low, or intermediate, so here's the recommended assessments. You know, to do these things in every patient. This is the things that have been added. Measurement of coronary artery calcification is reasonable for patients at intermediate risk. This is the first time this has been included. So you have an intermediate risk patient, it's reasonable. Now, reasonable means I think it's a 2A recommendation, and I'll show you what that means here in a few minutes. In patients over the age of 40 with diabetes, of course, that's a high-risk patient, measurement of coronary calcification is reasonable. So there's a lot of things that aren't recommended. So if they ask these sorts of things on a test, these are the things that are not recommended. So it doesn't do any good to parse somebody's lipids out into tiny little subtypes, which various organizations are perfectly willing to do for the patient and charge them an awful lot of money. But it has not been shown to be useful. Genotype testing, C-reactive protein in high-risk patients, and C-reactive protein in younger, low-risk patients, because you're not going to treat one group and you're going to treat the other group aggressively anyway, with or without that measurement. There's no reason to echo patients just for risk stratification unless they have some other condition like hypertension. stress echo is not indicated in low or intermediate risk patients. My colleague, who is the same age as me, has a risk of 9% on this new calculator, and they want to do an exercise stress thallium on him. I'm thinking, wait a minute. This is Kaiser that wants to do this. This is a not-for-profit group that wants to do this. I said, huh? Asymptomatic. Where'd they get that? Not recommended. Stress MPI in lower intermediate risk patients. Obviously didn't read the guidelines. See? Coronary calcification measurement in low-risk patients. CT angio is not indicated as a screening test. You see? My colleague notwithstanding. So now what about risk modification and prevention? So here is the risk factors for coronary disease. Which of these are independent risk factors? Do you know that? Age, male sex, LDL cholesterol, smoking, diabetes, and that's it, isn't it? All right, a 55-year-old man, which of the following risk factors is most predictive of the presence of coronary disease? So an LDL of 120, fasting blood glucose of 160, 60-pack year history of smoking stopping 5 years ago, LVH on an ECG, father died of an MI at age 68. Most predictive, the presence of coronary disease. Oh, guys, you got to know this. Diabetes, diabetes, and diabetes. Okay. Remember, diabetics need to be treated as if they have known coronary disease. They're in a high-risk group. Diabetics, peripheral vascular disease, and patients with over a 20% risk on one of the calculators, all high-risk group patients should be treated as if they have known coronary disease. We're coming to that. But none of the rest of these have that kind of predictive force. The smokers stopping 5 years ago has barely any risk above the regular population now for coronary disease. For lung cancer, yeah, not for coronary disease. Okay, so HDL cholesterol is clearly increased by aerobic exercise, decreased by smoking and androgens. A 35-year-old woman comes for a routine visit. She has no history of cardiac disease and a non-smoker. Her mother had an MI at age 70. Her blood pressure is normal. BMI is 28. LDL cholesterol is 169. Diet and exercise are recommended. She returns after 3 months and said she has tried to stick to her diet and is exercising twice a week. BMI and LDL cholesterol are unchanged. What should you do next? Add stuff or refer for a exercise and dietary counseling. Yeah, now it would depend on which guideline you read. See, the new guideline, the HA, the American Heart Association, American College of Cardiology guideline, would she get above 7% risk? I don't know. Probably not. If she did, then the new answer would be to treat her with a statin. The proper answer is E, and that would be 2. She hasn't done anything, right? So she needs some more professional help to try and reach some goals of weight loss and exercise. Just making some suggestions hasn't done anything. So she needs some more regular help, which you haven't got the time to help her with before you start adding medications. Now, smoking cessation decreases mortality and risk of reinfarction by 50%, and the benefits of smoking cessation begin within 48 hours by decreasing catecholamines. And catecholamines are our enemy in an MI, you realize that. That's why beta blockers prolong survival. Blood pressure control is reasonable, is recommended, but there's no data that demonstrates that controlling blood pressure decreases the risk of having a cardiac event. That's why it's just recommended. Now, even though diabetes is the risk factor that it is, how much data is there that demonstrates that elegant control of blood glucose decreases the risk of having a cardiac event? None. None at all. Now, it does a lot of other good things, but does not decrease the risk of having a subsequent cardiac event, in spite of that having been tested like crazy. Weight management. I can attest that I have had some success there. I was up there in Utah taking photographs, puffing up a hill, and I thought, you know, I'm carrying around a 100-pound pack. I said, this is stupid. I'm not doing this anymore. So I'm slowly losing weight. I just said, that's enough. And it's not easy, but I just couldn't take it anymore. So now my blood pressure, I went back to my primary care provider, and she was bugging me to go on an antihypertensive drug. And she walked in and she looked at me and she said, oh my gosh, because, you know, nobody loses weight. And my blood pressure was normal. She said, oh, you don't need nothing. So I was so happy, and she was happy. And so, you know, I just thought about walking up that hill, puffing up a little hill in Utah. This is stupid. So now I get consults from my colleagues, you know. My patient's short of breath, and their echo shows so-and-so, and it's 65% ejection fraction, and, you know, they got pulmonary function tests that are normal. And I look at the weight, and the weight's 315 pounds. And I look back, and I says, you know, I put this in the console. I said, you know, I'll bet when they were in the military, they probably weighed 180 pounds. And you ask them what it would be like carrying a 120-pound pack around all day. Would they be short of breath? I said, why do you think they're short of breath? But that epiphany dawned on me when I was walking up the hill. So they don't need any cardiac therapy. They need weight counseling. At any rate, I'm not there yet, but I'm getting closer. Depression. It's reasonable to refer and treat patients with depression because depression is a significant risk factor, particularly post-MI. There's a 20% one-year mortality in patients who have clinical depression post-MI. Nobody knows why. But does it do any good to treat the depression? There's no data for that. But that doesn't mean we shouldn't treat it appropriately. There is no data to support using antioxidants or folic acid or vitamin E or any other such thing. That has been studied and showed no benefit. All right, acute coronary syndromes. The American Heart Association and the American College of Cardiology has taken a lot of heat over these new guidelines. I don't know if you recognize how much heat they've taken. And or what the issue is. And the issue, does everybody familiar with the mess in the guidelines right now? If not, I'll just tell you briefly what it is. And that is that anybody who has over a 7% risk of having a cardiac event in the next 10 years theoretically needs, well, not theoretically, their recommendations are to treat that person with a statin. It doesn't make any difference what their cholesterol is. Doesn't make any difference what their LDL cholesterol is. It doesn't, and subsequently, they're not even recommending checking. Thank you very much. So if you don't think that has created a storm of controversy, now, you know, some of us wonder whether that should apply to everybody, because my risk is 7%, and I ain't going to take no statins. And how'd I get 7%? Just by being as old as I am, right? And I don't have any other risks. So, and the only reason I'm cheating is because I happen to know I don't have any coronary disease. But I still think that's a little crazy. The benefit of treating somebody with severe coronary calcification versus the benefit of treating me without any coronary calcification has got to be different, you'd think. But, you know, it's very controversial. Okay. So I chose to be fairly pedantic about this next section, and that is the levels of recommendations in the American College of Cardiology, American Heart Association guidelines. Class 1 indications are that the benefit greatly outweighs the risk. The procedure or the treatment should be performed or administered. Class 2A means the benefits considerably outweigh the risk, and it is reasonable. That's their key word there. So whenever you saw me use the word reasonable previously, that's where I was getting that word. It is reasonable to perform the procedure or administer the treatment. Additional studies are needed. Benefit means that Class 2B means that the benefits probably outweigh the risk and may be considered, but additional studies are definitely needed, and Class 3 means don't do it. It may be harmful. Now, the level of evidence, level A is multiple randomized trials. Level B means a single randomized trial or non-randomized study, and level C is expert consensus. Now, some things you're never going to get randomized trials. You're never going to get a randomized trial whether it's appropriate to treat somebody with a gunshot wound with surgery or observation, right? So some things don't lend themselves to randomized trials. So in general, chest pain is absent quite frequently, and it's more commonly absent in patients who are elderly. Women and diabetics may present with something else. Heart failure not infrequently. Atrial fibrillation, which is a marker for heart failure in this case. Here's a short list of the differential diagnosis of chest pain. Now, someone presents with what appears to be ischemic discomfort at rest. The electrocardiogram demonstrates either ST segment elevation or not. Cardiac biomarkers then may be negative or positive under these circumstances. That leads to a final diagnosis of unstable angina and what in the past has been called non-Q-wave MIs or Q-wave MIs. And why don't we use these terms now? because the development of a Q wave takes too long. We need to do something now. A woman came up and asked me a question whose roles is in the emergency department. She can't take the time to decide or to wait to see if a patient develops a Q wave, which may take 12 to 24 hours before she decides what to do with the patient. You have to decide now. So this takes too long. You have to decide on the basis of whether there's ST segment elevation or not. Why did we decide make that the marker of what to do? I'll show you where that came from. Most residents and people who've been in practice don't know why we made that the marker of what to do. But I will show you that. All right, now, what's the difference between these two? Non-ST segment elevation events are either unstable angina or non-Q wave MI. The patients usually have known coronary disease, not always, but usually. They usually involve less myocardium. So, you remember what prognosis is related to? LV function, correct? So, if you knock off less myocardium, are these high risk or low risk events? Generally low risk events. However, they have a high risk of recurrent MI or death. So you should think of NSTEMIs as little infarcts trying to become bigger ones. So even though their initial prognosis is not bad, at 1 year, if you don't do something about them, they have the same prognosis as a STEMI because of recurrent infarction. So if you were to develop a strategy for dealing with NSTEMIs, what would your goal be? Prevent recurrent infarction. Huh? That's the goal. Now, a STEMI usually develops a Q wave. The infarct size is usually larger. The initial prognosis is worse. Now, if you were to develop a strategy to deal with STEMIs, what would that be? Decrease the amount of myocardium lost with this event, right? And you appreciate the difference between these. Okay, everything is predicated on those two differences between these events and why we have separate guidelines for them. All right, what's the distribution of these things? Well, STEMIs don't comprise a very large proportion of infarcts anymore. And if you look at 1960s, mid-60s data, this is completely different. STEMIs were the big thing. Now you can go through all kinds of data and reasons why that might have had a huge shift, but it has been a big change. Now, management. So this says take a nitroglycerin. If it doesn't work, call 911. It's reasonable to get a pre-hospital ECG, and if you have the capability to have EMS telemetry that ECG to a center that can interpret the thing. If a patient's had an out-of-hospital arrest, it's reasonable, this is in the guidelines now, to have therapeutic hypothermia applied if they have the capabilities. Better CNS protection. And of course, those patients ought to have angiography and PCI performed at their center. Now, within 10 minutes after arrival in the ED, they should get all this stuff. Now, clearly this requires a team approach. One person's not doing all these things. And I like to tell the medical students, What's a focused history and physical examination consist of? Not much, huh? My 5 questions? No, not even that. I just want to know, well, if you're not sure that they're really having angina, maybe. That's true. Physical examination, I told the students on the CCU rotation, if I see one pupil is equal or responsive to light and accommodation, you flunk. Say, I don't care. Unless they have a big neurological deficit, I don't care. But I want to know the neck veins, and I want to know that S3. Don't tell me about peripheral edema. See, I don't care. Give me the neck veins. Give me third heart sound. Give me stuff that's specific. I really like specificity. Now, here's the symptoms. You all know that stuff. Now, use one of the scoring systems to calculate their risk. All of these are available as an app. The guidelines refer to GRACE. You can use any one of the 3. These will calculate the risk of having a myocardial infarction or death in the hospital or within 6 months. So patients at high risk need, obviously, big time intervention. What do these 3 have in common that makes you high risk? Older age. Heart failure is going to get you high risk any old time. Hypotension, angina, ST segment changes, positive markers are all bad things. Now, I'm going to show you a series of tables like this. I know I'm violating the 7 lines per screen rule for good presentation, but I couldn't think of a better way to do this. I decided to make them colorful just to make them stand out. What you want to do is do the green stuff. That's why I'm doing it this way. Do the green stuff. Don't do the red stuff. All right? So get biomarkers and do a cardio-specific biomarker. That's what that says. And don't get non-specific biomarkers. That's the short version. Here's the timing of biomarkers. If you saw there that if you really want to get something really fast, maybe if you have the ability to get a myoglobin, it's a 2B recommendation. And if your hospital had the ability to do it, and the thing about myoglobin, it's so very fast. The thing is, it's not specific. If you bump your leg, a myoglobin goes up. The thing about myoglobin, though, is if a person does not have a myoglobin elevation, they are not having an MI. It's as simple as that. It is the utility of the thing. Now, is anything about these curves related to the size of the infarct? Or are these just general trends? Oh, they're very closely related to the size of the infarct. If you get them often enough and draw a curve like this, it's the area under the curve that's related to the size of the infarct very accurately. All right, now this thing looks awful, but it is a crucial flow chart. And it comes from the NSTEMI guidelines, right out of the NSTEMI guidelines. The old little booklet had it as a pull-out chart you could take with you. Probably still is in a pocket guideline. So patients presenting with symptoms suggesting of coronary myocardial ischemia. So by you doing the 5 things, you put them in one of these categories, right? Markers, history, physical, ECG, whatnot. So maybe they have a non-cardiac diagnosis. Doc, it hurts in my left shoulder. It's been there for 3 weeks. Every time I do this, it gets worse. Okay? Now they go here. So maybe they have chronic stable angina, and for some reason they decided to see you. Well, we have a guideline for this. Chronic stable ischemic heart disease guideline. Now, possible acute coronary syndrome and definite acute coronary syndrome. If they have non-diagnostic ECG and they have normal markers on the first draw, you observe them for 4 to 8 hours. If they don't have recurrent pain, then they can get a stress study of some sort. If you have suspicion that they may have abnormal LV function, you could get that evaluated. If not, then do it as an outpatient or something. Now, if they're really low risk, and the guideline goes through what that might be, you could even do that as an outpatient. If they have a stress study that's negative, they have a low risk for an acute coronary syndrome and out the door. How long is this supposed to take? Huh? 8 to 12 hours. Now, if they're being observed and they have an ugly looking ECG or their markers go up, then they get admitted and managed toward via the unstable angina and STEMI guidelines. If you put them on the stress test and they get a positive stress study, then they get booted to this too. Wait a minute now, that means you just exercised somebody who had unstable angina, right? Is that okay? That's what this says. Yes, it is okay. It's been demonstrated to be safe. Well, now maybe they have a definite acute coronary syndrome. They don't have ST elevation, but they have ST T-wave changes, or they have ongoing angina-like pain, or their markers bump, or they have hemodynamic abnormalities. Well, they too get treated here. Now, if they have ST segment elevation, or a presumed new left bundle. Now, where'd that come from? We just threw that in just to add confusion, right? Where did that come from? That too will be explained. These people get evaluated for reperfusion therapy, and they get managed by the STEMI guidelines. All right. Now, CT angio is an acceptable alternative for a stress study. It's a 2B indication, and probably a 2B because it's expensive and because not everybody can do it. If you can do it, and the expense doesn't matter vis-a-vis the VA, it's probably a good thing. All right. Now, this is the preferred strategy with the invasive versus the conservative strategy. Look at all the patient characteristics there. Do you think that a patient is more likely to get an invasive or a conservative strategy? What do you think? The only people that I see that get a conservative strategy after an in-STEMI are patients who seriously have either refuse an invasive strategy, which happens, or who have some disease that means that they are not a candidate for cardiac catheterization. They have severe dementia, or they have end-stage cancer and really are not likely to survive much longer or something of that kind. Otherwise, virtually everybody gets cardiac catheterization. So patients get medical therapy. Other medical therapy, you should stop non-steroidals, except aspirin. The rest of this deals with calcium, with morphine is reasonable, and the rest of it deals with calcium blockers. So there are no great indication for calcium blockers, And there is a contraindication to dihydropyridine calcium blockers, the short-acting form, which is nifedipine and its cousins. That's contraindicated. Now, antiplatelet and anticoagulation strategies. These are similar to patients with STEMIs in that the patients are managed invasively. Patients are managed conservatively who develop high-risk features and subsequently have invasive evaluations. Now, I debated myself as to how much of this stuff with the anticoagulation strategies to burden you with. I struggled for days and days with trying to condense this information down into something that was usable for you. I rewrote this and threw out every tiny word of excess verbiage, which was incredibly long-winded. Then I threw caution to the wind and asked everybody I knew who'd taken boards. There I said it on tape. If this stuff had been on the test, and I got a universal no from residents, from fellows who had just taken boards, and from people who were recertifying, and everyone. Be that as it may, I still present it in as compact a form as I possibly can here, because I don't trust them. That's really why I've got it here. So I'll try and be as brief as I can and try and hit only the stuff that's either green or red. Okay? So aspirin should be started and continued forever. These are antiplatelet therapy in patients managed conservatively. Some sort of P2Y12 inhibitor, which is the simple way of saying clopidogrel, ticagrelor, or one of the other agents that are available, should be started in addition to aspirin and given for 12 months. That's pretty much routine no matter what strategy you're going to use, whether it's invasive or non-invasive, whether they get a stent that's drug-eluting or non-drug-eluting, that's pretty much routine. And some of these other agents should not be used if the patient is not going to get a stent. So abciximab should not be administered in patients in whom PCI is not planned. And a 2B3A is not indicated in some patients who are getting aspirin and the P2Y12 inhibitor. Now, what about revascularization therapy? We're going to talk more about anticoagulation in a minute. That's not the end of it, unfortunately. What about revascularization therapy to prolong survival? I can't imagine that they won't ask something here. So who gets what kinds of revascularization strategies will prolong survival? This is not treatment of symptoms, this is prolongation of survival. Unprotected left main, okay? Or complex coronary disease. So the combination of bypass surgery and coronary intervention or stent placement, you should use a heart team approach. In other words, the surgeons and the interventionalists should work together. Oh, good, that's a class 1 indication. Nobody has any problem with that. What's the STS and the syntax scores? These are various ways that the cardiologists have of determining how serious the coronary artery disease is and what the likely success of doing coronary intervention is. Okay? Now, what about an unprotected left main lesion? Now, this is different than it has been before, because in the past, left main was surgery, and that was the end of the story. So this is the newer guidelines, and this now has the window or the door or a little tiny mouse hole, something open for PCI of the left main. So bypass surgery is a class 1 indication. Now, for stable ischemic heart disease, when both of the following are present, there's an anatomical low risk and the clinical conditions that increase surgical mortality is greater than 5%. It's a 2A recommendation to consider unprotected left main PCI. Okay? There's the door opened. It's also open a little bit for unstable angina in STEMI patients if they're not a bypass surgery candidate for some other reason. And the other situation is for STEMI patients when the distal coronary flow is not good and PCI can be performed more rapidly and safely than CABG. In other words, if the patient's dying and the flow in the coronaries is so bad that you're not likely to be able to get them to the cath lab, to the operating suite and get them on bypass fast enough to save the heart. And the anatomy is favorable for PCI, the left main, do it. That's what that says. Now, I've seen this. Because it takes a while to get, and even getting the patient on cardiopulmonary bypass, you realize, does not save the myocardium under these circumstances. They've got to get blood flow restored to the heart. All right? Now, a contraindication is for stable ischemic heart disease with unfavorable anatomy for PCI who are good candidates for bypass surgery. Well, duh. All right. Now, 3-vessel coronary disease, prolonged survival to send patients to bypass surgery. Now, a 2A indication for PCI, it is reasonable, see that word again? To choose bypass surgery over PCI in patients with complex 3-vessel disease who are good candidates for bypass surgery. Not the same level of data. PCI for 3-vessel disease is of uncertain benefit for prolonging survival. Do you see that? 2-vessel disease with proximal LAD disease, bypass surgery has been shown to prolong survival, cut and dried. PCI is uncertain benefit, prolongation of survival. Single vessel disease, if it includes the left anterior descending, bypass surgery is reasonable to prolong survival if you can use the left internal mammary graft. Now, LV dysfunction, bypass surgery probably prolongs survival if the ejection fraction is 35 to 50%. Now, if you've survived sudden death, and it's probably because of ischemia-related VTVF, either one has been shown to prolong survival. So how many here have been, how many of these has PCI shown to prolong survival? Those are the hard facts, folks. Now, let's move to improving symptoms. So, at least one significant stenosis and unacceptable angina in spite of maximum medical therapy according to guidelines. Well, either one indicated. and onward down the page. Okay? So the clear indication is unacceptable symptoms in which in which the patient has not responded to maximum medical therapy. Now go back to my guy that had the 13.5 Met treadmill and had a positive stress test at big double product, a big rate pressure product. You still sure you want to send him to coronary angiography? What if you gave him a beta blocker and put him back on the treadmill and now his heart rate got to 120 instead of 180 and he didn't have any ST segment depression or symptoms? You sure you want to do cardiac cath? See what I mean? Cardiologists love to do cardiac catheterization. That was my thing. I just never happier than when I was in the cath lab. I taught 75 or 80 fellows how to do cardiac cath. I was the one who got the new fellows to teach them cardiac cath. I loved it. All right. So what about STEMI? This has been altered. So this is new stuff, prime stuff to be asked. STEMI patient, initially seen at a PCI-capable hospital. That patient needs to go to the cath lab for primary PCI. If the first medical contact to device time is less than 90 minutes, that's a 1A indication. In other words, that one's been demonstrated by multiple clinical trials to be beneficial. The diagnostic angiogram may then show that the patient needs medical therapy or PCI or bypass surgery. But typically, if it's an infarct-related artery, the patient should have PCI. Initially seen at a non-PCI capable hospital, if the patient can have primary PCI within 120 minutes of the first medical contact, then they should go to the PCI capable hospital. If they can't, and it's within 30 minutes of the first medical contact, they should have fibrinolytic therapy if they're a candidate. They probably, 2B indication, or 2A indication rather, should be transferred to a PCI capable hospital if they have evidence of a failed reperfusion or a reocclusion. And they probably ought to be transferred subsequently anyway for observation. A 2A indication. Now, what about primary PCI and STEMI? Ischemic symptoms less than 12 hours, a 1A indication. Can't get any more solid than that. So ischemic symptoms less than 12 hours and contraindications to fibrinolytic therapy. It's a pretty good indication. Cardiogenic shock or acute severe heart failure, irrespective of time delay. That doesn't matter how long it's been. Why? Because the alternative is death. So, the contraindication is to fool around with the non-infarct related artery while you're in there. Don't do that. You might come back to that later at some point, but not under the acute circumstances. Here we go. So just bear with me. So, quick review, aspirin, P2Y12 inhibitors, clopidogrel, prasugrel, and ticagrelor. And we have 2B3A inhibitors include antagonists abciximab, tyrofibin, and eptifibatide. These are antiplatelet aggregate inhibitors. We have heparins, unfractionated heparin, and the low molecular weight heparins of bivalirudin and fondaparinux, and we have warfarin. Okay, aspirin irreversibly inhibits cyclooxygenase, which is necessary for thromboxane synthesis, therefore inhibits platelet aggregation. The P2Y12s irreversibly binds to the receptor of that name on platelets, which inhibits cross-linkage. It's a different mechanism than aspirin. The 2B3A's receptor antagonist somewhat reversibly binds to the receptor bearing its name and inhibits platelet aggregation. So we can hit the platelet from 3 different sites, receptor sites. Heparins do something else. Unfractionated heparin binds to and activates antithrombin 3, which inactivates thrombin and factor 10A. Low molecular weight heparin binds directly to and inactivates factor 10A, so it works more directly than unfractionated heparin does. Warfarin is like taking a shotgun at the coagulation system because it inhibits the vitamin K dependent synthesis of factors 2, 7, 9, and 10. So there's your review of how the things work. So probably if you looked at this page, you'd be home free. What this says is that aspirin should be loaded with a moderate loading dose. This is patients with PCI for acute STEMI, but it more or less holds for everything. And 81 to 325 milligrams, nobody knows exactly what, is the maintenance dose. 81 milligrams may be the preferred dose, maybe not. Who cares? Now, what about the P2Y12 inhibitors? They all have a loading dose when you're going to use it for PCI with an acute STEMI. Would they ask you these loading doses? They might ask clopidogrel, maybe clopidogrel, because it's a lot more than the daily maintenance dose. I'd probably know that one. 600 milligrams, a pretty big dose. Would they ask prasugrel or ticagrelor? I don't think so. Now, does it matter whether there's a drug-eluting stent or a bare metal stent? More data that's accumulated? Probably not. There's a big concern, of course, about drug-eluting stents having late stent stenosis. And most of the data that's come out has shown that that's not a problem. So you see the maintenance doses are really the same. Now, should there be continuation of clopidogrel, prasugrel, ticagrelor beyond 1 year? I don't know how many consults I get from our community-based clinics of patients that come in, their primary cardiologist has them on one of these things forever. Never stop taking this. And I say, that ain't the guidelines. Just for your knowledge, the VA has said that it will consider to allow prescriptions under 4 circumstances. If the original PCI was for a left main, if it was for a stent at a bifurcation of a coronary, if it was for a stent within a stent, a restenosis, or if it was a stent in a graft. Those 4 circumstances. So that's what I say. If the patient can produce a cath report that the stent was placed for one of those 4 things, I'll let it go. If not, no. I had a consult this morning before I came down here. A patient was admitted for a GI bleed. He was on clopidogrel for a stent placed in 2008. Can we stop it? This was an inpatient consult. And he had an apical thrombus that was present in June of 2008 and was not present in September of 2008 by echo. And warfarin had been continued ever since that time. No new echo was obtained. So he's on warfarin, aspirin, and clopidogrel. And they wanted to know, could they stop anything? Yes, yes, well, yes, no, and yes. Aspirin's okay. Okay. I don't think they'll bother you with this page. I have it in there because it's 2B, 2 A's and 2 B's, and I don't think they'll bother you with it. However, you should know that heparin, unfractionated or low molecular weight heparin, is indicated to support PCI. Are they going to bother you with the doses? I don't think so. Just know that heparin is a class 1 indication to support PCI for an acute STEMI. And fondaparinux is not recommended as the sole anticoagulant for primary PCI. Well, nobody's going to use it in that role. There was just one study tried to do that and it didn't work. Okay? This went on for pages and pages and pages. So that's as boiled down as I can get it. Go look at the guidelines. It'll make your head go around and around and around. Okay, fibrinolytic therapy. Okay, reperfusion at a non-PCI capable hospital. If the patient has had, if there's going to be more than a 120-minute delay from the onset of symptoms to the primary PCI, is fibrinolytic therapy is a class 1A indication, no doubt about it. Now, if the patient has ongoing ischemia more than 12 to 24 hours after symptoms and a large area of myocardium is at risk, and you can't get to somebody to do a PCI, then they need, that's a reasonable indication for fibrinolytic therapy. And don't give fibrinolytic therapy when there's an in-STEMI. That one they could well ask. See that? Put a circle around that. See that class 3 indication? Where'd that come from, by the way? Could that have some reason why we have separate guidelines for in-STEMIs and STEMIs, I wonder? Well, funny we should ask that question. This is where all of the reasons for separating into the 2 guidelines came from, right here. I was involved in some of these trials. Do you think that patients with NSTEMIs, the ones with ST segment depression, down here on the right, this bunch, I'm slowed down here a bit, I know, because you got to understand this. Do you think that this bunch down here, if you looked at the coronary arteries of these people, are their coronary arteries different pathologically from this bunch? Do they have plaque rupture and thrombus formation? Or some other kind of pathology affecting these guys? Huh? No. It's exactly the same pathology. They have plaque rupture and thrombus formation. The only reason that this is a ST segment depression is usually these are patients who have had previous infarcts, or they have multivessel coronary disease, and this is just a little tiny branch. Or they've had bypass surgery, and this is a tiny little, the lost their bypass graft, or something. Remember, these people are ones that usually have already had known coronary disease? Remember way back when we started talking about NSTEMIs? These are little nibbles. But it's the same pathology. Plaque rupture and thrombus formation. So, in the 1980s, why wouldn't, the question was raised, why would they not respond to fibrinolytic therapy? This was before PCI. Wouldn't that make sense? Seem reasonable. So multiple studies were started giving these patients fibrinolytic therapy. And to everybody's horror, this was the outcome. A negative effect on survival. Why would that be? Because fibrinolytic therapy is not like giving aspirin. Fibrinolytic therapy is a potent therapy. It kills people. I know, I have done that. Causes intracerebral hemorrhage. Okay? So the risk outweighs the benefits here. Remember what the treatment strategy is here? Not to prevent loss of muscle from this event, but to prevent reinfarction, okay? Because this event does not involve much muscle. So what is the line here, if you wanted to draw a line through these things? What is this slope? What is this risk slope? LV function. Of course it's LV function. Which brings me to the other thing that I promised I would tell you about. What has new left bundle got to do with anything? Why is it there? Do you really think that new left bundle, the conduction abnormality, really has any effect on survival? No, of course not. But what kind of an infarct does it take to get a new left bundle? A huge one. It's the size of the infarct that it takes to get a new left bundle. Do you understand? That's the problem. It is a humongous infarct. So it's LV function that's driving this. And what it turned out was that these didn't lose hardly any LV mass, so fibrinolytic therapy as a treatment was worse for these patients than medical therapy otherwise. Okay? All right. So all you got to do here is to know one thing. TPA and IV heparin. Don't worry about the rest of these agents. TPA and IV heparin. The Gusto trial was the last trial that will ever be done. So, 44,000 patients comparing all of the fibrinolytic agents, and the combination of TPA and IV heparin had the best survival rates. So nobody's going to do that trial again. That's the only thing you got to remember. Okay, here's the absolute contraindications. They will ask this stuff. So these are the bad things. Here are the relative contraindications, and these are the problems, because this is what eliminates patients. Not very many people have those other things, but this is what eliminates people from being candidates for fibrinolytic therapy. Chronic, severe, poorly controlled hypertension. You know any of your patients like that? That's the guy I killed. I thought I could get away with it. I couldn't. Significant hypertension on presentation, ischemic stroke, dementia, intracranial pathology, traumatic or prolonged CPR, major recent surgery, recent internal bleeding, non-compressible vascular punctures, pregnancy, active peptic ulcer, oral anticoagulant therapy. Hypertension is the big problem. So, antiplatelet therapy with fibrinolytic therapy. Aspirin is reasonable, and so are clopidogrel. Some kind of heparin is necessary with fibrinolytic therapy. Remember what I said about the Gusto trial? TPA and heparin, okay? So indications for transfer for angiography post-fibrinolysis. So if you can transfer somebody, heart failure or cardiogenic shock or heart failure should go. Who should you cath post-fibrinolytic therapy? Cardiogenic shock. You better, they haven't got any other chance. Intermediate or high-risk findings on pre-discharge non-invasive ischemic test. In other words, if you give fibrinolytic therapy and post-fibrinolytic therapy, you do a stress test post-fibrinolytic therapy before discharge, and they drop their ST segments 3 millimeters, you got to cath that person. If they're walking around the ward afterwards and on telemetry, the telemetry monitor is watching the ECG, and they spontaneously have ST segment depression on the telemetry monitor, that's a bad thing. Or they have an episode of flash pulmonary edema, which is probably, and somebody gets the echo probe and sticks on there, and they have acute LV dysfunction, that's a bad thing. Or if somebody takes the stethoscope and happens to listen to them while they get real short of breath during an episode, and they hear a new MR murmur, that's a bad thing. See? So what about PCI of the infarct-related artery after fibrinolysis? Patients in shock. You got to do everything you can possibly do. And it has been shown that PCI of the infarct-related artery, even if it's far down the road in a patient with cardiogenic shock, does improve mortality. Something better. Okay, otherwise, as we'll see in a minute, they're muerto. Okay? Now, it doesn't help to do PCI of an occluded artery more than 24 hours post-STEMI in a stable patient. That would make sense. Now, this is very similar to the patients who have a STEMI, so I'm not going to go through that. It's actually the same thing. And this is the same thing as far as the length of time to get P2 Y12s. 1 year. And as we've said before, unfractionated heparin needs to be given with fibrinolysis. Now, what about medical therapies post-STEMI? It's reasonable to give nitroglycerin for ongoing pain. Also for hypertension and heart failure. But don't let that stop you from treating the hypertension or the heart failure or the chest pain with definitive therapy. Don't mask it with just giving nitroglycerin. And there's a dose there. Don't give it with suspected RV infarction. I'll come to that in a second. Don't give it if the patient's hypotensive. Don't give it if they've had a recent phosphodiesterase type 5 inhibitor. What's that? Sildenafil. Thank you for the translation. Okay, oxygen is reasonable. Okay, what about morphine? Morphine is a great drug for patients having a STEMI. It decreases pain, it relieves anxiety, and you don't want anxiety having somebody having a STEMI. Why not? Increases catecholamines. And catecholamines do all kinds of bad things in patients having a STEMI. You go down a list and list at least 10 bad things that catecholamines are doing. One of them is increasing platelet stickiness. You know that? You don't want those kinds of things happening. They're arrhythmogenic, aren't they? Go into atrial fib, VT, all sorts of bad things. Oral beta blockers. Here's the contraindications. It's nice that beta blockers, you have to think only of the contraindications, otherwise they all get them. Oral, not IV. Here's the contraindications to beta blockers. Signs of heart failure acutely, evidence of low cardiac output, increased risk of cardiogenic shock, which I have a slide on, long first degree AV block, second or third degree block, active asthma, has to be active asthma, not just a history in the past of asthma, that doesn't get it. Continuing after the hospitalization, and reassess the patient every 24 hours to see if you can start giving them, because catecholamines are our enemy in the case of ischemic heart disease. Cardiogenic shock risk. This is the people who are at risk. Old people with low blood pressure, relative tachycardia. What does that mean? The baroreceptors are not happy. You see, they're not being perfused well. So they're using catecholamines to support perfusion. Long duration of time since the onset of the acute coronary syndrome. So what about the renin-angiotensin-aldosterone system inhibitors? ACE for anybody with an EF less than 40%. An ARB is an acceptable alternative. An aldosterone antagonist is indicated in patients already receiving an ACE or an ARB and a beta blocker with an ejection fraction less than 40% who have either symptoms of heart failure or who are diabetics. All right? And have a creatinine that's above, creatinine clearance above something or other. I can't remember what. And are not hyperkalemic, obviously. So high-intensity statin therapy should be started or continued in all STEMI patients. Did you see a measurement of cholesterol there? So urgent CABG is indicated post-STEMI with coronary anatomy not amenable to PCI who have ongoing ischemia, cardiogenic shock, severe heart failure, or high-risk features. and or mechanical complications. We're going to talk about that in a second here. Now, it's reasonable to assess risk after a STEMI. If you haven't had an angiogram, it's reasonable to assess risk in some fashion, usually by some kind of a stress study. So you ought to have an assessment of LV function on everyone prior to discharge. Since we tend to return our patients to their primary care providers in my hospital, just to make sure everything is smooth, we have a post-acute coronary syndrome clinic. Within 4 weeks of discharge, every patient who's had an acute coronary syndrome comes back to that clinic once to check the results of all their risk stratification, how they're doing, whether they're symptomatic, do a careful physical exam, see if they're in heart failure, check their echo, check everything out of the studies that have been done since discharge to make sure that everything's okay for the transition back to their primary care provider. We've done that for about 6 or 7 years, just to make sure. And they have an assessment of the risk of sudden death to make sure they're a candidate or not for an ICD. So cardiogenic shock, we'll talk more about that in a second, but these patients should have some kind of emergency revascularization if there's anatomy that can be done for that. Now, these patients also should, if patients have symptomatic bradycardia, they need to be paced. This is the simplest indication in the world. Symptomatic bradycardia is an indication for at least temporary pacing. That's all you have to remember when we're talking about pacemakers. You don't have to remember the kind of block they have, nothing. Symptomatic bradycardia is the indication for pacing. Some patients should get an ICD before discharge, and those include patients who have had VTVF more than 48 hours after the index infarction as an inpatient. Those patients shouldn't go home without an ICD. Other patients, you should wait the standard 45 days and get an echo and see what their ejection fraction is. Pericarditis should be managed with aspirin. All right. A patient is admitted to the CCU with chest pain and suddenly develops a narrow, complex, irregular tachycardia. Systolic blood pressure is 70. What should you do? Administer adenosine, administer beta blocker, administer diltiazem, perform synchronized cardioversion, administer amiodarone. Good. And the indication for emergency cardioversion is a symptomatic tachycardia, well, other than sinus tachycardia. Hemodynamically unstable tachyarrhythmias require immediate cardioversion. A 74-year-old female was admitted after 4 hours of substernal chest pain. ECG follows. 2 hours after admission, her blood pressure fell to 60/40. Neck veins are elevated. All right? Well, there's the ECG. A right heart cath is inserted for some bizarre reason, and following pressures are obtained. Right atrial pressure is 19, RV is 30/17, pulmonary artery is 31/17, the wedge pressure is 12. What's wrong? Tamponade, cardiogenic shock, papillary muscle dysfunction, RV infarction, VSD. All right, well, most of you got that. Tamponade, she doesn't have equalization of diastolic pressures, right? 12 for a pulmonary capillary wedge pressure is not anywhere near equal. So why would she have tamponade anyway? She'd have to have rupture of a free wall. She wouldn't have any blood pressure. She'd be muerto, right? No, not that. Papillary muscle, cardiogenic shock, she wouldn't have a wedge pressure of 12. It'd be 30, okay? Papillary muscle dysfunction, same thing. She'd have a wedge pressure off the charts. RV infarction is exactly the picture. You have a right atrial pressure that's elevated way over the pulmonary capillary wedge pressure. VSD, she'd have a wedge pressure that was exceedingly high again, and boy, would she ever murmur. Okay. RV infarction almost always occurs with right coronary occlusion, and associated with an infero-posterior MI, usually. Suspect RV infarction with a triad of hypotension, clear lung fields, and an elevated jugular venous pulse. And they have Kussmaul sign. When they breathe in, the neck veins go up. Okay? By the way, what other, we haven't covered this yet, but we will. What other thing, it's back on that table, remember the neck vein table I gave you and told you we'd cover it later? What other thing on that table is associated with a Kussmaul sign? Constriction, thank you very much. Absolutely. So why would these people have a physical exam finding of constriction? That's strange. Well, it isn't so strange. You get an RV infarction. What's a poor RV to do? It dilates, boing, up against what? The normal pericardium. And it develops some of the physical findings of constriction, including Kussmaul sign, or the inspiratory rise of the neck veins, you see? Now, they have transient ST segment elevation in the right side of chest leads, not infrequently. This thing is always on boards, always. RV infarction is there 80% of the time, I'd say, in some form or another. Mitral stenosis and its chest x-ray is always there. When we get the valvular heart disease, never fails. That's an absolute gimme point, all right? This is there 80% of the time. Sometimes they put this with, they'll give you V4R, V4 right over here, and they'll show ST segment elevation, dead giveaway. Okay, the things that you have to do is, they have, the triad is, they have big neck veins, hypotension, and clear lung fields. See, they don't have cardiogenic shock and pulmonary edema, which would go along with left heart failure. So they have hypotension, big neck veins, and clear lung fields. See? Now the treatment is fluids, and if that doesn't work, dobutamine if hypotension persists. And what they don't want you to do is to give volume depleting therapies like diuretics, big neck veins, don't give diuretics, or nitrates, which can just make this a mess. Okay? So they like this. These people that write the boards like this thing because it gives all these nifty physical exam findings, Plus, if you do the wrong thing and try and treat this patient as if they have heart failure, you can kill them, see? So they get really excited about this. All right, a 56-year-old man presents with an acute inferior MI by ECG and markers. 2 hours after admission, he becomes profoundly hypotensive. Features that would support the diagnosis of an RV infarction include all of the following except a third heart sound heard at the left sternal border, neck vein distension on inspiration. You had Dr. Professor Kussmaul, right? Pulmonary congestion on auscultation, ST segment elevation and right-sided chest leads, and echo showing RV dilation and hypokinesis. Ah, good, see? All the rest of this, what's the third heart sound on the left sternal border? Right ventricular S3, right? These are really easy to hear because the RV's right here. It's a dead giveaway. Really easy to hear. Next time you have somebody that comes in with severe COPD and you see their neck veins, sit them up, see their neck veins up to here. Listen with the bell, right here or right here. Jeez, pulmonary hypertension. Get the echo. Then you see the 70 millimeter mercury pressure. Go, I didn't need that echo. I knew, right? Put your hand here and feel the left peristernal lift. Boom, 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 boom. The RV pounding against your hand. All right, none of the rest of this stuff would, all these other things are findings of RV infarction. Okay, now VTVF, if it occurs right at the time surrounding the infarct, it doesn't affect prognosis. However, if it occurs more than 48 hours after the index infarction, it occurs with LV dysfunction, and that's bad. Okay, ventricular tachyarrhythmias, convert them if they're unstable. Stable VT, these are ACLS doses of amiodarone. Okay, 72-year-old woman is admitted with acute inferior MI. 2 hours later, she develops a heart rate of 32, accompanied by lightheadedness and diaphoresis. The most appropriate therapy would be that stuff. Yeah, atropine, reasonable therapy, right? She probably has some kind of high-grade AV block. That would be a reasonable therapy. It'd help to look at an ECG, but most likely that's the thing to start with. And that is the dose. That's an easy dose to remember, and it's the ACLS dose. Okay, pacing in an MI is really easy. Symptomatic bradycardia. All right? Type 1, first degree and type 1, second degree type 1 rarely require pacing, only symptomatic bradycardia for that one. Higher grade AV block usually does need pacing. Okay, what about an inferior versus an anterior MI? The inferior MI is usually smaller, therefore the prognosis is better. AV block is fairly common with an inferior MI. Now why is that? Because the AV nodal artery comes off the distal right coronary 85% of the time. And you can occlude the distal right coronary and have a relatively small infarct size, therefore the prognosis is not bad, but you can have acute ischemia to the AV node and get fairly high-grade AV block with this, you see? But the prognosis is not necessarily bad. However, if you get AV block with an anterior infarct, it means you nailed both bundles in the septum. And that requires a large infarct, and the prognosis is terrible, 40 to 60% in-hospital mortality, because of the size of the MI. Again, it's always related to LV function. And patients that have the inferior MI and have episodes of AV block don't need pacing. It's usually temporary, unless they have symptomatic bradycardia. All right, a diabetic patient presents with unstable angina. The ECG shows new T-wave inversion in the precordial leads. What should be done next? Immediate coronary angiography, observation for 8 to 12 hours, a regular exercise stress test with nuclear perfusion imaging, or dobutamine stress echo. Go back to that flow chart. This is one of the questions that is alarmingly similar to something that's been asked before. Ah, yes. Now, why is that? Because that's a high-risk event, isn't it? New ischemic changes is a high-risk event. And according to that flow chart, if you're observing this patient and they get new evidence of ischemia, that vaults them into the admitted column and treated according to the NSTEMI guidelines. And according to the NSTEMI guidelines, new evidence of ST segment changes is a high-risk event, if you'll recall, and that would be an indication for angiography. Now, a 73-year-old man with typical angina for the past 12 hours is admitted to the ICU. Initial exam is normal. ECG follows. Troponin I, it peaks at 45. Is that a good number or a bad number? That's a bad number. Okay? There's his ECG. Three days after admission, he suddenly develops severe hypotension and dyspnea. Physical exam shows elevated neck veins, diffuse pulmonary crackles, a precordial thrill, and a left parasternal lift, none of which is good. Chest x-ray shows that. Physical exam also shows a loud, harsh, holosystolic murmur, heard best at the lower left and right sternal borders and every other place you care to put a stethoscope. What is the most likely diagnosis? Free wall rupture, rupture of a papillary muscle, acute VSD, cardiogenic shock, RV infarction. Yeah, that's the bad one. This is the bad one. Free wall rupture, he wouldn't be laying there having a murmur. He'd be muerto. Rupture of papillary muscle, you wouldn't have this murmur all over the place. This is acute VSD, and this sort of pansystolic murmur heard loudly all over the place. I've heard 3 of these in my career. They're all ugly. They're all very bad, and this is the kind of guy who would get one. Big anterior MI. You get a papillary muscle rupture with an inferior infarct, not an anterior MI. And mortality is in excess of 70%. Well, that's very bad. Okay, here are the 4 catastrophes. And any analogy with the 4 horsemen of the apocalypse is only tangential. These are free wall rupture, papillary muscle dysfunction, VSD, and cardiogenic shock. Now, the setting, they do like to ask stuff about these things. So the setting is of a free wall rupture is an anterior MI in old hypertensive women for some reason. They present with syncope. They really do ask that. They present with syncope. It's kind of like the big league syncope, you know, like death. They pass out all right. They pass all the way out. They have signs of tamponade for a little while. The diagnosis, I mean, they have big neck veins, you know, and I guess they have pulsus paradoxus if you can get a blood pressure cuff on them in time. And diagnosis is by echo. There are a few heroic saves with urgent CT surgery, not very many. Mortality is 95% plus. I've seen two patients actually come in, two patients come in with a ruptured free wall that have survived as outpatients and come in and they actually come in and they have a blood swirling around in the pericardium with a big hole in the free wall. Oh yeah, I felt bad about 6 weeks ago. Huh? Yeah. Papillary muscle dysfunction. These are usually an inferior MI. They present with shock, sudden onset of shock, because we'll talk more about that when we talk about mitral regurgitation. They have a systolic murmur that may be very short and hard to hear, and I'll explain that when we talk about acute MR. The diagnosis is by echo, the management is CT surgery. If you catch this, the mortality should be way less than 50%. In this day and age, the mortality should be pretty good. It should be probably 10 or 15% if you make the diagnosis. If it occurs in a setting in which people are on their toes and make a quick diagnosis, this is not that bad anymore. Because the infarct size, remember, affects mortality. This does not require a big MI, just ischemia of the papillary muscle. Okay, VSD, this is a miserable thing because they have this huge, ugly, dead septum and they rupture. And the problem is because of the size of the infarct and because the surgeons, when they go in and try and fix this, they have to take a big piece of pericardium and slap it on the LV side of this thing and then take these big sutures and get as far away from the defect as they can. And the surgeons say it's like sewing into cottage cheese. You know, to find some viable muscle to put this patch. And if the patch rips out, dead. Cardiogenic shock is characterized by patients just on echo is again the way to make the diagnosis. These are large MIs on top of old MIs. That's what they usually are. And on echo, this is what you see. This business. See? Something may be moving, but not much. And they have shock, and the mortality is exceedingly high, very bad. And it's been demonstrated that urgent PCI of their infarct-related artery may improve the prognosis. Okay, here's my medication chart. We'll talk more about the ones that prolong survival in heart failure. I've got the ones that prolong survival in post-MI here. What's a negative dromotrope, by the way? AV nodal blocker. So beta blockers are powerful AV nodal blockers. Okay. A patient with acute coronary syndrome has a history of 5 asthma episodes in his life, each time associated with a respiratory infection. An ECG shows ST segment depression, EF is 35%, cholesterol is 120, although in this day and age, so what? What medication should be administered? aspirin, beta blockers, ACE, and a statin, or just aspirin and an ACE, beta blockers, ACE inhibitors, and a statin. Well, you can read the rest of it. What would you give this person? Yeah. Now, the thing to realize here is that 5 episodes of asthma, each time associated with an upper respiratory infection, do not constitute a contraindication to beta blockers. Not when beta blockers can prolong survival post-MI. Not at all. Given the beta blockers, if it causes an exacerbation of asthma, well, then deal with that. But certainly don't withhold it. All right, don't use NSAIDs unless you absolutely have to, and then use a non-selective one if you have to. Basically, older patients are at higher risk for having a procedure. They have higher complication rate and higher risk. However, they're also at higher risk for complications of coronary artery disease, and they have more to gain from a procedure than anybody else does. So don't arbitrarily withhold invasive procedures from elderly patients as long as you consider their other comorbidities. That's what all of that says. A 27-year-old male presents with chest pain, agitation, tachycardia, and hypertension. ECG follows. What should you order? CT angio, stress test with nuclear imaging, NSAIDs, urine drug screen, IV diltiazem. All right, good. You don't need a stress test to make a diagnosis of what's going on in that ECG. So of the 500,000 ED visits by cocaine users in 2005, at least 40% complained of chest pain. And cocaine and other catecholamine-like drugs can cause acute coronary syndromes and aortic dissection, sometimes days after use. Nitroglycerin and calcium blockers are the drugs of choice. Now, coronary angiography is indicated if the chest pain persists, or if the ECG shows ST segment elevation, or if cardiac markers are elevated. If none of these are present, the patient can be discharged after 9 to 12 hours. The use of beta blockers is controversial. Methamphetamine patients are managed the same way. Now, here's the audience response questions. Which of the following patients would be most appropriate for reperfusion therapy? Now, there's a big old long answer here, but see if you can break this down into who is the best candidate for reperfusion therapy. All right, well, let's go through this. First, tell me if there's a contraindication to fibrinolytic therapy, and then we'll work on who is the best candidate for fibrinolytic therapy. 47-year-old man with 4 hours of chest pain who has 2 millimeters of ST segment elevation in inferior leads. Any contraindication? No. Is he a candidate? Yeah. All right, he may not be the best candidate, but let's leave him in the pool, okay? 80-year-old woman with a recent onset of right hemiparesis. Oops, she's out. Now she has 4 millimeters of ST segment elevation and leads V1 to V6. That's tempting, but she's out, okay? 75-year-old man with 3 hours of chest pain and a new left bundle branch block. It'd be hard-pressed to find a better candidate than that, right? That's got to be the answer. A 65-year-old man with 3 millimeters of ST segment depression and new T-wave inversion in leads V1 to V4. No, that's an in-STEMI. A 72-year-old woman with 3 hours of chest pain with tall R waves and ST segment depression in V1 and V2. She's in, that's a true posterior, and we'll talk about that more when we come to the ECG part. We'll talk about true posteriors. The reason why they like that and usually include one on the test is because of trying to confuse you with a true posterior. But that's in. But clearly, of the 3 that are in, the one with a new left bundle has the most to gain, right? Okay. 75-year-old woman with a previous MI and heart failure comes to the ED with 3 episodes of syncope in the past 24 hours. That's a bad sign. Now, what would you think of if you had somebody with heart failure, known heart failure, starts having syncope? What's the cause of the syncope? VT, right? Decreased LV function, VT, you think of that. If it's not orthostatic hypotension, if you rule that out, that's pretty easy to rule out. Then you have to think of VT. Physical examination demonstrates an apical third heart sound, and all that implies. Her initial ECG follows. What would you see in her neck veins? Well, that went sideways. Okay. So what does that show? So the way you should start with, the statement you should start with here, that's a wide complex tachycardia, right? Now, if you wanted to use anybody's criteria you wanted to use in analyzing this thing, this is VT. We'll talk a little bit about that when we talk about the ECG, but any way you want to parse this thing, this is VT. So if you want to be really careful about it, you can actually pace out the P waves here in V1. There are actually separate sinus rhythm going on here in V1 if you're really good with a set of calipers. So this is AV dissociation, all right? So now, what would you see in her neck veins? Regular X and Y descents, irregular canon A waves, positive Kussmaul sign, large A waves and a slow Y descent, engorged neck veins without pulsations. Now, how do we get from severe heart failure and VT to this? Thank you. Thank you, thank you. Right? She has AV dissociation. Correct? She doesn't have constrictive pericarditis causing rapid X and Y descents. She doesn't have a Kussmaul sign from an RV infarct. There's no reason to blame that. She doesn't have tricuspid stenosis, D. She doesn't have a superior vena cava obstruction. That would be E. So she does have AV dissociation from VT. All right, 68-year-old man comes to the ED with 12 hours of chest pain. Heart rate is 70, blood pressure is 90/50. There are irregular canon A waves in the jugular venous pulse. Boy, is that a gift. See, now you know that is a big present they just handed you. So the ECG, if they're going to show you one, is either going to show what? VT or a complete heart block. And he has an apical third heart sound. There's another gift. He's not doing very well. Which of the following statements is true? Well, what is it, VT or third degree block? Okay. I don't even need to paste those, to produce calipers on those P waves. I already know what it is. There's sinus rhythm going on, and there's a separate junctional escape rhythm. This is complete heart block. Okay, now what's the problem acutely? Well, he's got an acute inferior MI, doesn't he? See the ST elevation and 2-3 and AVF? That's the acute problem. Is that his biggest problem? It's not the third degree block, is it? That's not his biggest problem. What's the biggest problem? Huh? Somebody said it. Say it again. The S3 is his biggest problem, right? Absolutely, that's his biggest problem. Now, why does he have an S3? From an acute inferior MI? They ain't going to give you an S3. What's giving him the S3? Ah, this stuff, right? The old aneuroseptal infarction, plus the new one, you see? Old coronary disease and now new coronary disease. That's the problem. Yeah, so he's got complete heart block. Big deal. You understand? The S3 is the bad thing here. It shows that whatever he's doing isn't enough. Now, does he have symptomatic bradycardia? I mean, his heart rate's not that slow. It's what, 70, no, it's 68 or so. What is that? Does he have symptomatic bradycardia? Does he have an indication for pacing? Huh? No, there's nobody's going to bug you here. Does he have an indication for pacing right now? Irrespective of the third degree block? Yes. Why? Because because he has, what does symptomatic bradycardia mean? Does he have near syncope? What symptoms? Does he have syncope? Does he have evidence of heart failure? Does he have angina? Does he have hypotension? 2 out of 4 ain't bad, huh? Right? Oh yeah, he has symptomatic bradycardia, all right. He really does. So yes, he has an indication for pacing, maybe AV sequential pacing, because he needs everything he can get, you see? All right, what's the question about, though? Fibrinolytic therapy is likely to markedly decrease his 30-day mortality. He is likely to require a permanent pacemaker. Temporary transvenous pacing is not necessary at this time. An echo showing an LVEF of 30% would be an indication for coronary angiography. This patient has an excellent prognosis. No. Fibrinolytic therapy is too far out for fibrinolytic therapy. What is it, 12 hours, 20, what is he? Too far out. And 30-day, and an inferior MI is not going to have a lot of difference with fibrinolytic therapy. Okay? He needs coronary angiography, that's for sure. He probably needs coronary bypass surgery. Is he likely to require a permanent pacemaker? Remember I said that the acute inferior MI complete heart blocks are probably not permanent? Does he need temporary pacing? Yes. He has symptomatic bradycardia. An echo showing an LVEF of 30% would be an indication for coronary angiography. Yeah. Did you need it as an indication for angiography? No. Everybody'd get one, but did you really need it? The S3 was enough. This patient has a terrible prognosis, horrible prognosis. He's almost in cardiogenic shock, isn't he? Really, he fits the definition of cardiogenic shock. He has an in-hospital mortality probably in excess of 80%. All right. A 56-year-old man comes to the ED with 6 hours of constant dull chest pain. He has this pain at rest and with exercise lasting 20 minutes to several hours. What kind of chest pain is that? Non-cardiac pain? Yep. Physical exam is normal. Initial cardiac markers are negative and his ECG is normal. What should you do? Discharge him, start anti-anginal meds and arrange for outpatient follow-up. Observe him for 8 hours, draw another set of markers and obtain another ECG. Admit him to the hospital and start stuff. Immediate coronary angiography. Remember the flow chart? Was this question very similar to one on the test? Yes. Observe him for 8 hours, draw another set of markers, and obtain another ECG. It's exactly what the flow chart said. Yeah. Okay, 67-year-old woman has 3 hours of chest pain. She has no contraindications to reperfusion therapy. Which agent should you use? That's what this says. There's the same ECG. That's the ugliest one I can find, so I keep using it. So which one would you use here? This is an easy question if you remember it. Yep, TPA plus IV heparin. Right? 72-year-old male with known coronary disease presents with 3 hours of chest pain. Heart rate is 85 BP, 145 or 95. There's moderate elevation of the jugular venous pressure. First troponin is 13. His ECG follows. What would you do? Reperfusion therapy. Avoid beta blockers because of his heart failure. Perform a stress study to determine if coronary angiography is necessary. Treat him with medical therapy alone. Urgent coronary angiography. These questions are right in the meat of the test. I got to tell you this. See, you're getting this now. So he presents with an in-STEMI, right? He presents with an in-STEMI. He has ST segment depression. He has a high risk in STEMI. He has troponin elevation. He has persistent ST segment depression. Those are high risk findings. The flow chart says that he needs angiography, right? This is exactly what you should do. Patient with previous CABG has an ejection fraction of 25% by echo. A 24-hour Holter monitor showed 4 episodes of non-sustained VT. What treatment is appropriate? Amiodarone therapy, blah, 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 blah. So what are you going to do? Good. Now let me ask 2 questions here. Which is more cost effective for prolonging survival? The ICD or beta blockers and ACE inhibitors? They're pretty cheap, aren't they? Beta blockers and ACE inhibitors? The ICD is more cost effective. Oh yeah. Oh yeah. You don't have to treat very many people to pay for an ICD. They are really effective. Right. Second question, did you need to see the VT on the Holter to have this be indicated? No. Right. 24-year-old man developed chest pain at 2 a.m. while drinking and smoking marijuana. He presented to the ED at 10 a.m. with continued chest pain. ECG shows ST segment changes. Troponin is 2.4. What is the diagnosis? Myocarditis, methamphetamine abuse, pulmonary embolism, spontaneous pneumo, aortic dissection. You mean he lied? Of course he did. Yeah, that's right. Who, me? All right. Let's see. A 66-year-old woman presents with 2 hours of substernal chest pain. She has risk factors of diabetes, smoking, and dyslipidemia. Her ECG follows. What should you do next? Oh, this is awful. Nasty, nasty, nasty. Exercise test with nuclear imaging, CT angio, fibrinolytic therapy, stress echo, radionuclide ventriculography. Not bad. Most people actually got it. Okay? There's 4 diagnostic tests and a therapy here. And the therapy is right. This is a true posterior infarct. You're not supposed to have tall R waves in V1 or V2. Now, it'd be more obvious if she had a concomitant inferior infarct as well. We'll talk about this when we talk about ECGs more. Talk about true posterior. You're not supposed to have tall R waves in V1 or V2, accompanied by ST segment depression in those leads. We'll talk more about it. This is the thing, they love to stick this thing on a test. Usually you're going to see this in combination with an acute inferior MI with ST elevation in 2-3 and AVF, but not always. This is a true posterior, and it is a STEMI, and it is an indication for STEMI protocol. We'll come back to it. A 55-year-old man has had TPA for a STEMI. 3 days later, he had an episode of similar chest pain, relieved in 10 minutes by nitroglycerin. He has a pericardial friction rub. ECG shows nonspecific STT wave changes. What should be done next? Angiography, NSAIDs, prednisone, stress test with nuclear imaging, adenosine stress test with nuclear perfusion imaging. Yeah, cath this guy. Same kind of pain, relieved in 10 minutes with nitroglycerin. I don't care if he's got a rub. Cath him. Too much risk. Evidence of recurrent ischemia post-STEMI to the lab. So if he's got a little rub, yeah, he's got pericardial inflammation, so what? You got the same kind of pain relieved by nitroglycerin. Nitroglycerin's not going to relieve pericarditis. You got to go to the lab. High risk. 64-year-old man had STEMI and was treated with aspirin, beta blockers, ACE, and the statin. He was standing at the nurse's station when telemetry showed the following. What would you do? Naturally, you're in the call room, asleep, when this happens. Temporary transvenous pacemaker, refer for permanent pacemaker, an electrophysiology study, decrease the beta blockers, coronary angiography. There he is standing there, and you come running up with your big needle. Temporary transvenous, he's standing there talking, he's flirting with the nurses. And he thinks he's getting somewhere, and you run up with a big needle in a cart. Jeez. No, he doesn't. No. What is this? So it's second degree AV block type 1, right? So this is nothing. This is absolutely nothing. So he probably had a STEMI, an inferior STEMI, and probably his AV node is hurting a little bit from that. And so you give him beta blockers and you make it hurt a little more. And so make it hurt a little less. Decrease the beta blocker dose a bit. But he's asymptomatic. You know, second degree type 1 is just a little worse first degree block. So just decrease the beta blocker dose and leave him alone. Doesn't mean anything. It's certainly not an indication for a permanent pacemaker, and he doesn't need an EP study, and he doesn't need cardiac cath because of that. All right, a 74-year-old woman comes to the ED. You remember that the AV node is perfused by this AV nodal artery, and it gets tweaked with inferior MIs, and so usually this goes away. A 74-year-old woman comes to the ED with chest pain and dyspnea is found to have an NSTEMI. Physical exam and chest x-ray shows pulmonary edema with an NSTEMI. She is given beta blocker, morphine, nitroglycerin, and 160 milligrams of furosemide. Okay? She initially improves, but 1 hour later she becomes hypotensive. A right heart cath is inserted and the following pressures are obtained. Right atrial pressure is 2, pulmonary artery pressure is 20/6, wedge pressure is 6. What is the appropriate treatment? Balloon pump, emergency PCI, fibrinolytic therapy, normal saline infusion, blood cultures, and empiric antibiotics. Yeah, I think that was maybe a little aggressive with the diuretics. All right, so this is a chestnut-breasted coronet in San Isidro on the 6,000 feet on the east slope of the Andes in Ecuador.